my great pleasure to introduce Dr. Alison McGough-Maduena. She's our graduating senior fellow. She grew up in New Mexico and went to undergraduate University of Tulsa and then medical school and residency University of New Mexico. We're really fortunate and lucky to have matched her here with us. I know our patients have really benefited from her comprehensive and thoughtful care, so thank you for that. After graduation, she will be moving to New Mexico, back to her community, where she'll be a practicing GYN oncologist and also really taking care of the clinical trial program and training University of Mexico residents. So we're really so proud and excited for you. But for the next 10 minutes, she'll be introducing her work in the laboratory for the last in the year when she was there. And this work is really seminal in that it's making a contribution to how we think about tumors, not just as tumor cells, but also cancer-associated fibroblasts, and how depletion of a collagen receptor can actually improve sensitivity to PARP inhibitor, which typically would only be active in BRCA-altered tumors. So really setting the stage and making a really significant contribution to our field. So thank you, Alison.
Thanks for that introduction, Catherine. I appreciate it. And it's great to go after your presentation. This is a little part of my research journey, which has also not been a super straight path. And so excited to share with you guys today. All right, so we'll get down to the research. And as Catherine mentioned, I'm going to be talking today about DDR2 depletion of cancer-associated fibroblasts and how that enhances sensitivity to PARP inhibitors in ovarian cancer. So we'll start a little bit by talking about ovarian cancer and treatment. While the incidence and mortality rates have improved some over time, ovarian cancer continues to be a very deadly diagnosis. It is the 11th most common cause of new cancer, but the 6th leading cause of death in individuals assigned female at birth. The longtime standard of care has been a combination of platinum-based chemotherapy combined with the goal of optimal cytoreduction at the time of surgery. And this standard of care has changed with the discovery of PARP inhibitors, which is an oral maintenance therapy that has been shown to extend survival when given after platinum-based chemotherapy. PARP inhibitors have been shown to improve both overall survival and progression-free survival when used as maintenance therapy after chemo in patients with germline or somatic BRCA pathogenic variants. What I have showing here is some figures from the SOLO-1 trial, which was looking at olaparib as frontline maintenance in treatment of patients with new ovarian cancer with germline and somatic BRCA mutations or pathogenic variants. And you can see that the hazard ratio for overall survival demonstrates that there was a 45% reduction in the risk of death with the addition of olaparib maintenance, which is a pretty powerful improvement in survival for these patients. Now let's talk about PARP inhibitors for all comers with ovarian cancer, meaning patients with the aforementioned pathogenic variants and other homologous recombination deficient tumors, as well as patients with homologous recombinant proficient tumors. These are figures from the PRIMA study, which was looking at the use of another PARP inhibitor, niraparib, in this broader population as maintenance after chemotherapy. I wanted to draw attention to the top overall survival. Oh no, it's not there. Oh, there it is. Okay. Top overall survival curve with the top right that shows the overall survival for patients with homologous recombinant proficient tumors. That's objectively quite a bit shorter, as you can see from that of the homologous recombinant deficient subgroup, around a 30-month range versus around a 70-month range. And then when we look at the bottom curves for progression-free survival, we can see that while there's a difference in the PFS or progression-free survival in both the homologous recombinant deficient and proficient groups, it's smaller in the homologous recombinant proficient subgroup. This is relevant because about 50% of patients with ovarian cancer will fall into this subgroup with homologous recombinant proficient tumors that have a poor survival and derive less therapeutic benefit from the use of PARP inhibitor. And so this identifies a need for new treatments in this group, including combination therapy that might increase efficacy of PARP inhibitors in those HR proficient tumors. And so now we'll talk a little bit about discoidin domain receptor 2, or DDR2 as we called it around the lab. So DDR2 is a tyrosine kinase receptor that's expressed by ovarian cancer tumor cells, as well as cells in the tumor microenvironment and Today, we're going to be focusing on cancer-associated fibroblasts. This receptor's ligand is fibrillar collagen, and it's been shown through work in Dr. Fu's lab and others to have an established role in ovarian cancer progression via pathways that promote cell invasion, migration, and metastasis. Previous work from Dr. Fu's lab has shown that high DDR2 stromal expression in ovarian cancer is associated with poor clinical outcomes. You can see the image on my left, your right, shows IHC staining for DDR2 expression from a tumor microarray with stronger staining seen in tissue from patients with poor overall survival. And then the right is a survival curve demonstrating that same finding. Other prior work from the Fu lab has further demonstrated the importance of the stromal DDR2 expression. This figure is showing that in mouse models, knockout of DDR2 expression in stroma or the tissue supporting or surrounding the tumor led to smaller volume of tumor growth and longer survival compared to stromal wild-type DDR2 expressing mice. As Dr. Fu had talked about, little is known about the effects of treatment on the stroma that surrounds and supports tumors, and what effects that might have regarding resistance to treatments. Tumor stroma has a lot of components, including cells called cancer-associated fibroblasts, or CAFs. CAFs have an active role in remodeling the tumor microenvironment through collagen production and paracrine signaling to surrounding cells. And they are known to express DDR2, which we have established with the prior slides, has a direct role in enhancing tumor invasion and metastasis. CAFs have also been shown to have an intrinsic resistance to PARP inhibitors in preclinical studies and have also been shown to actually be activated by PARP inhibitors. The mechanism and effects of the interactions between CAFs and ovarian cancer cells is a new area of investigation that we're working on in Dr. Fu's lab. So given the established intrinsic resistance of CAFs to PARP inhibitors that have been seen in other work, we wanted to investigate if DDR2 plays a role in this resistance and also begin to explore the interplay between CAFs and tumor cell sensitivity to PARP inhibitor treatment. Thus was born my project, which we designed with the goal of determining if DDR2 depletion in CAFs would enhance CAF intrinsic sensitivity to PARP inhibitor therapy, and if DDR2 depletion in CAFs would affect or enhance homologous recombinant proficient tumor cell sensitivity to PARP inhibitor therapy. Patient-derived CAFs were previously isolated from BRCA wild-type advanced stage ovarian cancer omental tumors, and from these CAF lines, we selected CAFs with high expression of DDR2 at baseline. We also selected a homologous recombinant proficient ovarian cancer cell line to start with that has high baseline DDR2 expression and has been shown to have increased sensitivity to PARP inhibitor treatment with DDR2 inhibition. All cell lines were cultured in pairs with a passage-matched DDR2 knockout and scramble-controlled DDR2 wild-type line, and DDR2 expression was verified via Western blot. And you can see a picture of our CAFs here, which I looked at quite a bit over the course of that year. To address the question of the role of DDR2 in the intrinsic sensitivity of CAFs to PARP inhibitor, we designed this cell viability assay experiment that you can see diagrammed here. It took a total of 5 days. On day 1, we counted and seeded cells in a 72-well plate. After allowing them to adhere and grow for a day, we then prepared and treated the cells with a serial dilution of our PARP inhibitor, olaparib. This plate was then incubated with the treatment, and on day 5, we added our reagent, which was MTS, and then used our plate reader to evaluate absorbance and calculate viability looking at the IC50, which represents the concentration of drug at which we see a 50% reduction in cell viability. Then to begin to try and answer the question of how CAFs and modulation of DDR2 in this stromal component might impact tumor cell response to PARP inhibitor, we designed this additional set of experiments which had the same overall timeline, but included an additional step on day 2 in which we incubated the tumor cells in cultured media collected from our CAF cell lines. The idea behind this being that this would hopefully reproduce some of the effects that CAFs exert on tumor cells. So some data. Panel A on the left is the Western blot demonstrating expression of alpha SMA in both of the selected CAF lines. This is a marker that is expressed by CAFs, so helped us to identify that we were in fact working with CAFs. And then panel B on the right is a Western blot demonstrating expression of DDR2 in the paired CAF cell lines. So moving on to the viability assay data, panel A and B here show the dose response curves for the calf cell lines that we treated with olaparib and the corresponding IC50 for the paired cell lines. These two figures demonstrate that DDR2 depletion led to an increased sensitivity to olaparib in these calves, as you can see evidenced here by the lower IC50 for the knockout dose response curve, respective to that of the control. And then these are the results for our conditioned calf media assay, which ended up being pretty busy figures. Each dose response curve is color coded and represents a different condition from the various combinations of paired tumor cells and paired conditioned media combinations. The condition with the highest IC50 or the most resistance to olaparib in both experiments was the DDR2 expressing tumor cells exposed to the conditioned media from the DDR2 expressing calves. Interestingly, depletion of DDR2 in both components, so in the tumor cells and then in the calves used for conditioned media harvest, resulted in increased sensitivity to olaparib, but less so than DDR2 depleted tumor cells alone when treated with olaparib. So in summary, depletion of DDR2 expression in calves increase their intrinsic sensitivity to olaparib. And our data that I've shared some of with you today demonstrates that calf conditioned media does in fact modulate tumor cell response. Most notably, we observed that the greatest resistance to PARP inhibitors with DDR2 wild-type tumor cells was with DDR2 wild-type tumor cells exposed to conditioned media from DDR2 wild-type calves, indicating a somewhat additive effect on treatment sensitivity with the exposure to the conditioned media from the cancer-associated fibroblasts. And while depletion of DDR2 in tumor cells in calves used for conditioned media harvest did increase the sensitivity, it did not restore sensitivity to the same level as the DDR2 depleted tumor cells alone, indicating the presence of an antagonistic effect with this interaction. Future work in this line of inquiry is going to include some additional in vivo experiments using a DDR2 inhibitor molecule and olaparib to further characterize the mechanisms behind these results that we've seen, with special attention to the role of the immune response and metabolic changes. Thank you. Just wanted to say a quick thank you to Dr. Fu for leading me on this bench lab journey. I was a person who had never done anything in the lab outside of the prerequisite work that I did to go to medical school. So it was a huge learning endeavor. And in that same vein, I want to say thank you to the Fu lab team, which is pictured here, as well as the Robinson lab teams, because they really were there every day and answered my questions because I was learning all of these techniques and assays. And so it was a huge undertaking, not just for me, but the people that were supporting me. And then also a thank you to our Gyn-Oncology Fellowship leadership and all of the faculty who supported me. And then my past and present Gyn-Oncology Fellows, the Alisons, Yoon and Leah. And then a special shout out to the Rita Ann Brenner Endowed Research Fund that provided funding for parts of my project and for me to travel to conferences to share this work. And then, of course, a thank you to my family, especially my husband, Reed, who has kept our family life going while I've been working hard here with you all. So thanks, guys. Anybody has any questions? Yeah.
First of all, that was amazing work, having started where you started, so incredible. Second of all, for your abstract of all of them, I had to do my homework. This is like far outside of my professional comfort zone, but I did have a question. My question was about the DDR2 inhibitors that you talked about for future work. Are those used as medicines now, or are they too? I would expect that the DDR2 is all over your body. So are those? Is there any thinking that you could like combine a DDR2 inhibitor with a PARP inhibitor, or is the DDR2 inhibitors too toxic?
The hope is that we'd be able to combine the DDR2 inhibitor with the PARP inhibitor and reproduce the treatment effect that we've seen in these in vitro experiments. But of course, it would require kind of further investigation to see in perhaps phase 1 trials to determine if the toxicity is tolerable. But that's the hope. Yeah. Great. Okay. Thanks, guys.
Oh, great. We can have the introducers just come up so that you don't have to see me coming up every time. Do we have Vicky? Oh, great. Vicky's here. Come on up to introduce Diane.
Good morning, everyone. We have had the pleasure to train and now introduce Dr. Diane Ju. She is our one-year hospitalist fellow. She started her educational career at University of California, Irvine, where she got her bachelor's degree and then went on to medical school. After that, she joined a residency program at University of Texas, Rio Grande, where she completed 3 years and then went on to finish residency at OHSU due to the program shutdown in Rio Grande. Despite this, she was well regarded at both institutions where she received numerous teaching awards for her excellence in teaching. Today, she's going to present on C-section scar ectopics and a case series here at UCSF. Diane?
Thank you, Dr. Testis, for that kind introduction. Good morning, everyone. The topic that I'll be presenting today is the evaluation and management of cesarean scar ectopic pregnancies, a case series from UCSF. So starting off, a C-section scar ectopic is an early pregnancy that implants into the scar of a prior cesarean delivery. The reported incidence ranges from 1 in 1,800 to 2656 based on single center estimates, but the true incidence is unknown because this disease is commonly underreported and underdiagnosed. C-section scar ectopics and also placenta accreta spectrum share similar disease pathways and often exist on a common disease continuum. Now, C-section scar ectopic pregnancies have resulted in live births, however, are associated with placenta accreta spectrum, cesarean hysterectomy, massive hemorrhage at the time of delivery, and also maternal death. Because of the severe risk of high maternal morbidity, C-section scar ectopics are not, expected management is not recommended, and definitive surgical versus medical management is indicated at the time of diagnosis. Now, currently, there's more than 30 different treatment regimens ranging from medical, surgical, minimally invasive combination that exists in the literature without a standardized or known optimal treatment. The objectives of our study were to identify pregnancy-related and or imaging factors that were associated with successful treatment outcomes for C-section scar ectopic pregnancies. Now, treatment success was defined as only requiring one treatment modality. We also wanted to look at the management strategies that were employed for C-section scar ectopics at UCSF by the different providers. This was a retrospective case series that was conducted at UCSF, and the earliest cases dated back from 2006 to the most recent as of early April. All cases were identified through the radiological Empower database, and these cases were confirmed via the electronic medical record system. We collected patient demographics, pregnancy-related factors, imaging data, treatment approaches, outcomes, and also follow-up information as well. We were able to identify a total of 48 cases, 26 of which were managed medically and 22 that were managed surgically. Now, when looking at the patient demographics, comparing age, ethnicity, insurance type based on medically managed versus surgically managed cases, there were no statistically significant differences that we identified. However, for BMI, there was a difference for the medically managed group of 34.3 being the average versus 28 for the surgically managed group. When looking at the pregnancy characteristics, we looked into the gravidity, the parity of these patients, what gestational ages they were at the time of treatment, as well as if these pregnancies were achieved spontaneously or with the assistance of assisted reproductive technology, as well as what the HCG levels were at the time of treatment, and the total number of C-sections these patients had, as well as prior abortions, ectopic pregnancy, and also whether or not they were symptomatic at the time of treatment. Similarly, if you compare the two groups, we did find that there was increasing gestational age, specifically for those that were managed surgically, but otherwise there weren't specific differences between the pregnancy characteristics across both groups. Kind of zooming in onto the gestational ages, as you can see in this table, with increasing gestational ages, you can also see the increasing number of cases that were actually managed surgically. If you look at that bottom row, for the cases that were 10 weeks and above, we were able to identify a total of 5 cases that were treated and 4 of which were managed surgically. Now, if you look for those that were 7 weeks to less than 10 weeks, majority or about 63% were managed surgically, whereas those that were less than 7 weeks, majority or 75% were actually managed medically. We tried to see if there was a similar trend just by looking at the HCG levels, and then also to see if there was any kind of relative cutoffs that we oftentimes can see even with like tubal ectopic pregnancies to recommend maybe medical versus surgical management. For the HCG levels 10,000 or less, we did see that majority of them were actually managed medically, about 81%. However, for those that were greater than 10,000, there wasn't really a clear difference between those that were managed medically and surgically. Although here it looks like majority were managed medically, but truly once you're at a further gestational age, HCG levels are no longer even collected. So you're factoring in for the 10 cases that actually, majority of which were managed surgically. We looked at imaging characteristics and then also compared them across the different medical versus surgical treatments, looking at gestational sac size, crown rump length, whether there was a yolk sac present or not, as well as fetal cardiac activity, and also the residual myometrial thickness, which is essentially the thinnest measurement from the edge of the gestational sac to the uterine serosa or the bladder. And looking at all these characteristics, other than the gestational sac size being larger in the surgically managed group, there was no significant differences between the other variables. Although it seems that the yolk sac is present in more of the medically managed group, similarly factoring in for the fact that the further along the pregnancies are, yolk sacs are no longer even documented and further categorized in this case as unknown, but all of which were managed surgically. Now, kind of shifting gears a little bit, we plotted all the cases of our C-section scar ectopics from the earliest one in 2006 to 2025. And as you can see here, the medically managed group is highlighted in blue, followed by surgical management, which we started detecting more so in 2019. If you shift this a little bit and calculate the total number of cases that you can identify, we also added on those that were treatment failures or highlighted in yellow, required essentially another form of treatment, as well as the number of cases that was implied. And you can see in this distribution, there wasn't any specific kind of time point at which there were treatment failures identified. Looking more closely at treatment failures, there were a total of 10 cases that were identified, 23% in the medically managed group and then 18% in the surgically managed group. And of those that had failed medical management, half of them underwent medical management again, whereas only one of the cases ultimately required a third time treatment at which the providers decided to undergo medical management for the third time. As for surgically managed group, there was only one case out of the 4 that underwent medical management for treatment, but otherwise the rest was surgically managed. Now, what specific treatment types were employed at UCSF? As you can see here in this table, there are wide variations. Even in the medically managed group, there were 7 different treatment regimens, all with various combinations of local and systemic methotrexate plus or minus KCl, plus or minus the inclusion of a Foley balloon, as well as uterine artery embolization. And then similarly for the surgically managed group, putting hysterectomies to the side for now, but yes, under surgical management, there was variations of suction DNC, which documented with use of like the Berkeley machine versus manual uterine aspiration. There was hysteroscopic DNCs, plus or minus uterine artery embolization, as well as a diagnostic lab. There was one case that was a combination of suction DNC, including medical management with systemic methotrexate, but we classified that under surgical essentially. Now, for hysterectomy cases, there were a total of 5 cases that were identified, all of which got a uterine artery embolization as well. And all cases essentially were gestational ages of 12 to 13 weeks, except one, which was a primary treatment failure from a suction DNC. And it was found to have like an 8.6 hypervascular mass on MRI, concerning for PAS. We also looked at primary treatment method based on the provider type. And as you can see here in this table, majority of the medical management was performed by the maternal fetal medicine subspecialist, whereas majority of the surgical management was performed by the hospitalist, the complex family planning, and the MIGS subspecialists, whereas the generalist had a more even distribution of medically managed versus surgically managed cases. Now, while there was a noticeable difference in terms of treatment method by provider, one conclusion that arose from this is that once the treatment method was decided upon by the patient and also the provider based on shared decision-making, for example, if medical management was decided, then care was coordinated with the maternal fetal medicine specialist to provide the medical management, as opposed to saying that all maternal fetal medicines specialists preferred medical management. And although there was significant variability in treatment methods, as you can see just within the categories of medically managed groups or surgically managed groups, there was no clear side as having more treatment failures versus successes. We did see that surgical interventions were more common with increasing gestational age as well as gestational sac size, but there was no significant predictors of treatment success or failures that were identified, or other differences between the medically managed versus surgically managed groups otherwise. Now, when looking at the strengths and limitations, we were able to collect all of the identifiable cases within the radiological database that spanned across 2 decades. And because of the thorough documentation, we were also able to kind of illustrate all these various different treatment approaches that were actually implemented, as well as a detailed review of patient and pregnancy characteristics, treatment outcomes, and follow-up as well. In terms of limitations, this was a retrospective case series, and because of the low incidence, this was also a single center study, which makes it less generalizable and also had a limited sample size. The data completeness and accuracy varied sometimes based on, a lot of these patients were transfers from outside hospitals and earlier cases, even back from 2006, that did have missing data points as well too. And there was, a lack of standardized treatment kind of within each category of the medical versus surgically managed groups, which makes it harder to conclude that certain factors were associated more so with treatment success for either group. In conclusion, the study highlights the need for more evidence-based guidelines to help improve outcomes and having these personalized treatment plans that are tailored to patient-specific characteristics and also clinical circumstances that will lead to more safer and successful treatment outcomes. However, further research is still needed to identify these additional factors that influence treatment success, and then that way we can help create these guidelines for future management strategies. I'd like to thank everyone for your attention, and with special thanks to those listed below for their contributions to this project, as well as additional thanks to my primary research mentors, Dr. Tatsis and also Dr. Gonzalez, for help on this project since its inception. Thank you.
Really great talk. Thank you for that. I have just one comment and one question. The first is just sort of, this is a pretty big cohort that you have, right? I mean, I know it feels small, but C-section scar ectopic pregnancies are very uncommon. So I would just encourage you to sort of advertise this not as a case series, but like a retrospective observational cohort, right? It sounds like semantics, but I think there's a lot of like poo-pooing of case series, like they're not taking it seriously, but this is like a really nice, robust population. But my second comment is actually a question. So you show very nicely in that graph that there was, it looks like no surgical management before 2019. And I'm just curious if you have any ideas of what could have caused that temporal shift. Was there, are we doing did suddenly in 2019 we were catching all of these later, and so they're all later in gestation, and that's why they need surgical management? Was there some shift in like provider coverage, so fewer MFMs that are doing medical management of these cases, and now they're going to other providers to do surgical management? It's a pretty kind of stark change. I'm just curious what your thoughts are.
Absolutely. Yes. So the question is, in this table, why was there such a shift of all of a sudden surgical management appeared at 2019 and onwards? We thought about this as well too, in terms of why that was, and we didn't come up with a very clear answer other than maybe, in the earlier half from 2006 to 2018, we're only detecting like maybe 1 case per year. So there's a good chance with the under detection, we're actually not really catching the cases that were misdiagnosed as like an early loss or cervical ectopic that was just treated. And the other thing is, back in 2020 was actually when the SMFM consult series 49 came out for C-section scar ectopics, with further conversations in the literature regarding like improved detection and improved awareness. So you could see that sudden shift where we're also kind of getting a lot more cases all of a sudden. It's not that there's suddenly a lot more C-section scar ectopics, but I think we're just actually paying a lot more attention. We're just catching them. And so I think it's more of like a miss that we're not seeing them earlier, but there are cases that were actually managed surgically.
I would just
And probably in 2018, 2019, are seeing a lot more CFP folks on the UCSF side. We've always had, a presence on the UCSF side, but we've really been focused at. So with more people who are at the same time, I think somewhere around that time and more recently, there's just been more attention and more conversation about very effective for C-section start. So thank you for your presentation. This is really, this is one of several very cool overlap topics between complex and now I think most of us really sort of lean towards making sure that we're asking first, does this look like a SAC or a pregnancy where we could sort of really gently ask for a bit and then avoid other modalities?
Can you teach us a summary of the comment just for our Zoom audience?
Yeah. So a summary of the comment was that around, would say 2019 or so, that there was more of the presence of the complex planning folk that also contributed to the increasing treatments in terms of suction DNCs or surgical management, essentially. Yeah, that's proposed to.
Okay, it is my pleasure to introduce Adrian. Adrian completed his undergraduate education at UCLA and majored in microbiology, immunology, and molecular genetics. He then stayed on at UCLA to complete medical school training and then completed his OBGYN residency at Kaiser LA. And we're lucky to have him come and train with us at UCSF. I will have my notes because I didn't want to forget to say these important things. So at UCSF, Adrian has accomplished many wonderful things in addition to being a fantastic MFM. Those include being a part of the UCSF Advocacy Strategy Committee, through which he helped to structure the residency advocacy curriculum and also planned multiple documentary screenings centering around reproductive justice. Adrian has also been a part of the UCSF GME sponsored peer support ambassador program, which is a phenomenal opportunity. And he's made himself available and available for his peers in multiple capacities who have experienced adverse events at work. Adrian will sadly be leaving us and will be joining Kaiser Riverside, where he will undoubtedly bring phenomenal MFM care to his primarily Spanish-speaking population. And we're thrilled to all see all the wonderful things that you're going to accomplish, Adrian.
Hi, everyone. It's nice to see you all this morning. Thank you so much for that introduction, Dr. Sparks. Today, I will be presenting my thesis project entitled Factors Associated with Resolution of Non-Immune Hydrops Fetalis. And Dr. Sparks was, of course, my research mentor. I want to apologize in advance for my voice. I'm getting over a viral illness. I have no disclosures. Hydrops fetalis is defined as 2 or more fetal effusions, and it is associated with substantial risks of fetal and neonatal morbidity and mortality. This figure highlights the 4 compartments, including pericardial effusion, pleural effusion, ascites, or skin edema that could present. The majority of cases today are non-immune hydrops fetalis, and they may result from many different conditions, including those that are listed in this comprehensive table here. Ultimately, the prognosis for non-immune hydrops fetalis is dependent on the underlying cause. Factors such as a fetal genetic diagnosis and the gestational age at delivery can also modify outcomes. So for example, in the top left image, If a patient has polyhydramnios associated with hydrops, there might be a higher risk of PPROM and preterm labor and delivery, and that may impact the gestational age at delivery. Or if non-immune hydrops is associated with, say, for example, cystic hygroma, it may portend a worse prognosis as there are, given the association of a genetic etiology. Even when an etiology of non-immune hydrops is identified, it can still be challenging to estimate the prognosis during the pregnancy. However, fortunately, there have been certain fetal interventions, such as thoracoamniotic shunts, that have been shown to facilitate resolution of fetal effusions and hydrops in some cases. However, less is known about the likelihood of and factors associated with spontaneous resolution of non-immune hydrops. The existing literature is also limited by few prospective studies on this topic, small cohort sizes, and a lack of contemporary cohorts that have undergone modern genetic testing. This has led to limitations in our ability to counsel patients in the clinic about the likelihood of resolution and our ability to develop a surveillance plan. Therefore, we aimed to evaluate the likelihood of resolution of non-immune hydrops in utero. Our primary outcomes were defined as the frequency of resolution of non-immune hydrops overall, as well as spontaneously versus following a fetal intervention. Our secondary outcomes included frequency of resolution of non-immune hydrops in association with a fetal genetic diagnosis, additional structural anomalies, and live birth rate. We hypothesized that cases with isolated non-immune hydrops with no additional anomalies are more likely to resolve compared with cases with additional anomalies. We also hypothesized that an underlying fetal genetic diagnosis is associated with infrequent resolution, and resolution of non-immune hydrops is associated with a higher live birth rate. To study this, we conducted a secondary analysis of cases with non-immune hydrops from the National Hydrops cohort, wherein cases were prospectively enrolled between 2018 and 2021 from across the country. These cases underwent standard evaluation for non-immune hydrops fetalis, including diagnostic genetic testing with karyotype and/or chromosomal microarray. Those cases that did not receive a genetic diagnosis with standard testing underwent further testing, some with targeted gene panels and the majority with exome sequencing. Exclusion criteria were if there was a diagnosis of a clear infectious etiology, such as parvovirus B19 depicted on the bottom left, alloimmunization, or twin-to-twin transfusion syndrome, like in the image on the lower right. We also excluded pregnancies that underwent termination or had an intrauterine fetal demise before delivery, given the inability to ascertain a full phenotype in these cases. We obtained case-level data abstracted from electronic and scanned medical records and stored them in a REDCap database. This contained demographic details, medical, OB, and surgical history, along with other pregnancy or health complication information. We also obtained additional information on the index pregnancy, including fetal or maternal procedures that were performed, ultrasound imaging reports, laboratory results, including genetic testing reports, and antepartum and postpartum documentation. Approval was obtained from the UCSF IRB, and all participants provided informed written consent. For our statistical analysis, the primary and secondary outcomes are presented as proportions, while continuous variables are reported as median values with interquartile ranges. Multivariable logistic regression was also performed with models designed using directed acyclic graphs. We defined statistical significance as a p-value less than 0.05 or 95% confidence interval excluding 1, and we used Stata software for our data analysis. This flow diagram depicts the case selection for our study. Out of 213 cases, 132 were excluded due to the reasons listed on the right side. The final cohort included 81 cases, of which 64 had unresolved non-immune hydrops and 17 cases had resolution of non-immune hydrops, with further breakdown on the bottom in terms of whether cases underwent fetal interventions or not. And I will read those in more detail later. We found that the median gestational age was comparable between the groups, while nulliparity was more common in the cases where hydrops resolved. White was the most common self-identified race between the groups, and Hispanic or Latino was the next most common groups represented. When we looked at regions of the country, the majority were recruited from either the West or the Northeast. And there were only a few cases with a history of a prior pregnancy affected by one or more fetal effusions, and these were only present among the cases where hydrops persisted. The same was true for cases with a prior history of chronic hypertension. We also found that there was a higher incidence of hypertensive disorders of pregnancy among those cases where non-immune hydrops persisted compared with cases where it resolved. Regarding our primary outcomes, the final cohort again included 81 pregnancies, of which 17 or 21% had resolution of non-immune hydrops antenatally. Of these 17 cases, 10 or 59% had resolution of non-immune hydrops spontaneously, compared with 7 cases or 41% that had resolution following a fetal intervention. For our secondary outcomes, we found that a fetal genetic diagnosis was identified more commonly in the cases where non-immune hydrops persisted, 36% of cases, compared to cases where non-immune hydrops resolved, 29% of cases. However, this was not statistically significant. Conversely, fetal interventions were more common among cases with resolution of hydrops, 41% compared with an incidence of 28% in those cases where hydrops persisted, although this was also not statistically significant. When we looked at the incidence of any concurrent structural anomalies, 71% of cases with persistent hydrops had a concurrent structural anomaly compared with 47% of cases with resolution of non-immune hydrops. This trended towards statistical significance. And then when we looked at pregnancy outcomes, there was a 33% incidence of living neonates in cases where hydrops persisted, compared with a 100% incidence among cases where hydrops resolved. And this was statistically significant. When we performed multivariable logistic regression, we found that the adjusted odds of non-immune hydrops were not statistically significant considering fetal interventions or genetic diagnoses, but it did approach statistical significance when considering additional structural anomalies. And then among the 17 cases with resolution of hydrops, 7 cases had undergone fetal interventions before resolution, and this included 2 cases that underwent fetal thoracentesis, 2 that underwent thoracoamniotic shunt, and 2 cases that initially underwent thoracentesis and then subsequently had a thoracoamniotic shunt placement prior to resolution. And there was also 1 case that received antiarrhythmic medications for persistent fetal SVT. We also noted that the majority of cases with resolution of hydrops had an unknown etiology, or 65% of cases, while a genetic or likely genetic cause was identified in a minority, or 29% of cases. Among this contemporary national cohort of pregnancies complicated by non-immune hydrops fetalis, not explained by infection, alloimmunization, or twin-to-twin transfusion syndrome, 17 out of 81 cases, or 21%, had resolution. And this is in line with previous published literature reporting resolution rates between 5 to 26%, although we recognize the limitations of comparing our study with these older cohorts. The frequency of resolution was not clearly modified by an underlying genetic diagnosis, fetal intervention, or fetal anomalies. When we looked at other studies, for example, Mori et al. In 2024 reported a 31% incidence of a genetic or chromosomal disorder leading to hydrops in their study, which is roughly comparable to ours. Interestingly, the chance of a live birth was significantly higher in the cases with resolution of hydrops, being seen in 100% of cases, which is actually higher than previous reports, about 76%, which could be due to a number of different things, including potentially advances in medical care leading to decreased morbidity and mortality in the neonatal period. Whole exome sequencing also led to the diagnosis in 3 out of 5 cases of resolved non-immune hydrops that were ultimately found to have a genetic etiology. And it would have actually led to the diagnosis in a 4th case that was diagnosed on a targeted gene panel, which highlights the diagnostic yield of whole exome sequencing over karyotype and microarray. Some strengths of our study are the relatively large cohort, the fact that it was contemporary and cases had undergone more current genetic testing, and it was a diverse cohort from a geographic and racial and ethnic perspective. Some limitations included the small size of the subgroups, the heterogeneity in practice in terms of diagnostic evaluation across the US, relying on retrospective review of ultrasound reports, and that the outcomes of those pregnancies that were terminated or ended in stillbirth or miscarriage were unknown, which could have affected the results. Some ideas for future investigation include evaluating pregnancies with single fetal effusions to determine the likelihood of resolution in those cases, and also looking in more depth at secondary outcomes like genetic diagnoses with larger cohorts, and also separately investigating long-term morbidity associated with resolution of non-immune hydrops fetalis antenatally, including, for example, looking at neurodisabilities. In conclusion, we found that hydrops resolved in 21% or a minority of cases antenatally, of which 49% resolved spontaneously and 51% resolved after fetal interventions. There was a significantly higher live birth rate in cases with resolution of hydrops. These data are not only useful for counseling families encountering these complicated pregnancies, but also for anticipating outcomes and developing a clinical surveillance plan. I wanted to end by acknowledging and thanking, my numerous co-authors and my research mentor, Dr. Sparks, for continued support. She's been extremely patient with me during this entire process. And I also want to thank the fellowship program, the MFM division, as well as my co-fellows who are all just very such wonderful human beings, and the department at large, the residents who I feel very fortunate and privileged to have been a part of their education. And of course, my family, friends, and my partner for all being with me throughout this very long, arduous, but rewarding career path.
Short question. It's me again. Okay. Just looking at your 17 that spontaneous, that resolved, right? 6 of the 7 that were treated, they were all treated for pleural effusions, basically, right? A shunt or a tap. So it seems like if the pleural effusion is sort of the initiating cause of your hydrops, that's amenable to intervention. What about the 10 that spontaneously resolved? Do you know, did those also start initially as pleural effusions, right? Because I think if it's pleural effusions to hydrops, it's a different story than just like boom, 4 hydrops, and it helps with our counseling.
Yeah, that's a really great question. So the question was, looking at those cases that had undergone a fetal procedure, the majority of these essentially had intervention that was done for like a fetal pleural effusion. What about the 10 other cases? What sort of initial presentation of fetal effusions did they have? And looking at those 17 cases overall, there's a wide spectrum of presentations of fetal effusion. Some of them initially presented with just like potentially like skin edema or pericardial effusion. So it really was a wide spectrum of presentations for all the other cases. Thank you.
So good morning, everyone. Today, I would like to introduce Dr. Brett Stark. Dr. Stark had his medical degree at Georgetown University in 2018. He also received MPH degree at Harvard in 2017. And after the medical school, he actually joined UCSF. He did the OBGYN residency at UCSF and completed in 2022. And now he's with us at REI. So after the graduation, he's going to be continuing to practice in the Bay Area. And now I am actually leaving the stage to Dr. Stark for his presentation. Thank you.
Thank you for the introduction, Dr. Chakmak. So today I'm going to talk about regret, not my personal regrets. I have too many and there's not enough time for that, but rather I'll be talking about decision regret for patients who are trying to decide whether or not fertility preservation makes sense for them prior to gender affirming treatment. So to introduce this topic, I think it's trans patients are often faced with medical decisions that may negatively impact their future family building options. As such, it's generally recommended that we talk to them about fertility preservation prior to initiating gender affirming treatments. For our trans patients with ovaries, this looks like doing a controlled ovarian hyperstimulation followed by either egg freezing or by freezing embryos. This is a really invasive process, right? It involves multiple blood sticks, multiple transvaginal ultrasounds, exposure to high levels of estrogen, and can be really gender dysphoria inducing for a lot of patients. And so while gender affirming treatment is known to be life-saving and is associated with low levels of decision regret, we don't really know how fertility preservation fits into that picture. We've done some research looking at regret around fertility preservation. Most recently last year, Dr. Muckman and I and Dr. Sundaram, a prior fellow, published a paper comparing trans patients and their cis peers around this topic, looking at decision regret around fertility preservation. In this paper, we did a sub-analysis where we compared trans patients that did and did not do fertility preservation. And we actually saw that patients that underwent fertility preservation had lower levels of regret, which is a really surprising finding. And we were really intrigued to see if that holds up as true when we look at larger populations. There were lots of problems with the study. It was there were very few patients that actually underwent fertility preservation. There were only about 10 patients that had ovaries, 3 of whom underwent for egg freezing, so lots of problems. But we really wanted to see, we wanted to redo the study with a larger group of trans patients with ovaries to see whether or not fertility preservation was associated with increased decision regret based on the decision regret scale. We also wanted to see, are there factors that can predict severe regret? Is there something about some personal demographic information or baseline depression, anxiety, poor satisfaction with life that can predict severe regret in this situation, with the hopes of being able to identify those patients so that we can counsel them more appropriately? So the methods for the study, we of course worked with transgender and gender diverse individuals that were assigned to female at birth, people with ovaries. We looked back through from 2016 to December of 2023, and we contacted all of the patients retrospectively, inviting them to participate in the study to fill out the decision regret score. We tried to decide what was the appropriate amount of time between initial consultation and ultimately contacting this patient. We thought that 6 months gave people enough time to actually make a decision and potentially pursue fertility preservation if that's what they decided to do. All patients were given at their very initial consultation at UCSF the following scales: the Beck Depression Inventory 2, which is a scale looking at depression; the HADS, which looks at both anxiety and depression. For this paper, we only looked at the anxiety score. And then the Body Image Scale for transsexuals. Not my favorite title of a scale, but this is intended to look at body dissatisfaction in trans populations. And then ultimately, we also looked at the Satisfaction with Life scale, which just looks at overall how satisfied is somebody with their life. The meat of what we did at the follow-up was the decision regret scale. This is a five question Likert scale. It's a 5-part Likert scale. Ultimately, it adds up to 25. They're both the 5 questions are: it was the right decision, I regret the choice that was made, I would go for the same choice if I had to do it over again, the choice did me a lot of harm, and the decision was a wise one. As you can see, there are both positive and negative components to each of these, and so all of the questions are converted so that the higher number is the more negative thing, and the higher the score, the more regret somebody has. It's a 25-point score. We actually convert it to a 100-point score. And the way that we kind of break it down, and we'll look at this in a second, is that a score of 0 means no regret. Above 0, less than 25 is associated with moderate, a medium level of regret. And then greater than 25 is moderate to severe regret. And that'll be important in a second. Statistical analysis, I used data. We did the appropriate statistical analyses, whether or not it was a categorical or a continuous variable. And then ultimately, what we wanted to do is we wanted to see who are the people who get severe regret, who are those people that have a score greater than 25. And so we ultimately dichotomized the DRS scores so that we looked at everybody with a score above 25 and those with a score below. And then we did univariate logistic regression modeling to see what were the factors that were potentially associated with higher levels of severe regret. So jumping into the results, before we jump into this table, overall, there were 96 people that were eligible to be in the study, and we contacted all 96 of them. A total of 64 ultimately responded, which for our studies is actually a really high response rate. So we were really excited about that. The 33 people underwent fertility preservation and 31 did not. So overall, a pretty even number in both groups, which is really exciting. I'm not going to go through each thing here. I think it's, I just wanted to highlight overall, there was a surprisingly high amount of racial diversity. 45% of the people who did undergo fertility preservation were white and 38 that did not were white. And so just overall, we had more racial diversity than I was expecting. And then it's also just a very young and a very educated group. Not pictured here, about 50% of each people in each groups were less than the age of 18 and required parental consent to participate. So it was quite a young group, which was just notable. And probably also explains why the partner status is low in both groups. I mean, most people were in high school, so not partnered. Not listed here, but important. The average time to survey response. So the time from initial consultation to when they filled it out was 19 months. It was 19 months in the non-fertility, non-FP group, and in the fertility preservation group, it was like 15. So, and that was not statistically different. I apologize that it's not in the graph. So let's jump into the baseline mental health. I realize that these numbers mean nothing to most people, so we'll just kind of walk through it. Most importantly, look at the p-values. There's no difference in people who did and did not do fertility preservation. So just at baseline, everybody has about the same level of mental health. But what does that mean for these numbers? So the BDI 2, the higher the number, the worse the outcome. An 8 and a 7.5 are actually quite low. So these overall people were not depressed. For the HADS, higher the number, worse the outcome. And these are relatively low numbers as well. So not a lot of anxiety for our patients. And for the body satisfaction score, which is really measuring dissatisfaction, the higher the score, the more dissatisfaction. And so these are actually quite low scores. So overall, there's a low amount of, I won't say there's satisfaction with their bodies, but there's a low level of dissatisfaction with their bodies. And then the opposite is true for the SWLS. The higher the number, the more satisfaction with life. And generally speaking, people overall were very satisfied with their lives. So in summary, a relatively happy cohort, right? Not a lot of depression, not a lot of anxiety, overall satisfied with their lives, which is maybe not necessarily representative of the overall trans population globally, but we'll talk more about that in a second. This is the meat of what we did. This is our bar graph looking at decision regret in both people who did and did not do fertility preservation. And as you can see, the medians for the two groups really aren't, they're not different. This is actually the opposite of what we saw in our pilot study, right? Like we saw a statistical difference prior, and now we're seeing no difference, suggesting that people there's really no difference in regret for people who do and do not do fertility preservation. Kind of jumping more into these numbers, about 40% of patients in both the fertility preservation and the non-fertility preservation groups had zero regret, had a score of 0, which I think is pretty remarkable, right? That's actually a relatively low amount of regret. I feel like I regret most things that I do. So it's the fact that there's no level of regret was really, I think, impressive and shows that across the board, people had low levels of regret. Now, looking at that opposite side of things, how many people had severe regret? And the people who underwent fertility preservation, about 9% of those individuals had severe regret. And that was actually, interestingly, not statistically different, but notable that in the people who did not do it, about 20% of those people had severe regret. So even though that was almost double, it just with our low numbers, it really didn't play out as statistically significant, but I think it's still notable to point that out. And then we wanted to then focus on who are these people with these like high numbers, right? Like who are these outliers? Who are the people with the severe regret? Is there anything that we can do to predict who are these patients? So as I previously mentioned, we dichotomized our scores to 25 and above being severe regret, and less than that being not severe regret. And then we looked at a myriad of factors. We looked at age, education. We looked at, and then all of those baseline mental health markers. And ultimately, there was no difference. And so we really couldn't find any marker that was predictive of severe regret. So full disclosure, the decision regret scale is not intended for this purpose. You're really supposed to use it as an entire score, but we're in academics and we like to beef things up. So we wanted to take a look at each question individually. And I just wanted to highlight that while there's really no statistical difference across the board at each question, people who underwent fertility preservation were more likely to say that the decision that they made was a wise one, which I think is important to point out. I think that maybe that is indicative of just the confidence that they have in their overall decision making. But I think I just wanted to point that out as well. It's hard to read into that too much just because you're not really supposed to break down the DRS like that. But I just wanted to point that out. So discussion, obviously a lot of limitations with this research. I highlighted a few times that overall we had really good mental health in this group, right? And that's just not, I think it really limits our generalizability of the study. I think the majority of our trans patients are really connected to care, have access to gender affirming care, have really supportive families. And I think that really, that is not representative of the majority of trans patients, especially with the current administration and like kind of where things are going in our society today. We're also very limited by our retrospective design, right? Like there's a lot of recall bias. I contacted these patients. There's a lot of people are more likely to give more desirable results. There are a lot of just like negative things about it being a retrospective design. I think we're also limited with our short follow-up duration. I would guess that with an 18-month, I would hypothesize that there's probably like a bimodal distribution of regret with these types of situations, right? Like there's probably immediately post-procedural regret. If you had a complication, if something went wrong, you're probably more likely to regret what happened, or regret doing a procedure. I anticipate that 10 years from now, 20 years from now, whenever it's time to actually start building families, I feel like there's probably going to be more of a divergence in the levels of regret that we see, where people who no longer have that option to build their family might have more levels of regret. And so we're not really capturing that here. And it's something to consider in the future. Like, how can we capture people who had the option, had the opportunity, and ultimately didn't decide to do fertility preservation? I think that's something that's important to consider. And then I don't want to talk too poorly about our sample size. It is one of the largest studies, and it's really hard to get big studies for trans reproductive healthcare research. And so while it is a small sample, and I think that probably is likely why we didn't see the statistical significance we were hoping for, I think it's still impressive, an impressive number of patients, but it's still a limitation that we have in our research. Okay, so conclusions. The big thing is that there's no difference in regret. And I think clinically why this is important is that you can show this to a patient and say, hey, whatever decision you make is likely going to be, you're going to be happy with the decision. And so you can really use this as a way to say, if somebody's nervous about doing fertility preservation, nervous about like what the potential outcomes are, you can kind of say, you can trust yourself. Like if this is something that you want to do, the likelihood that you will regret this is quite low. I also want to highlight that there were no difference, that mental health markers were not predictive of severe regret. I think that's really important because I think that poor mental health is often used as a way to discriminate patients about getting care, right? And so we can say, hey, even though overall people had really good mental health, there were patients that didn't meet criteria for depression in this, and there was no difference in whether or not they regretted it. So I think that's like a really, really important thing to note as well. Now, we shouldn't be using these markers as ways to exclude patients from care. Not that we would do that at UCSF, but I could see a world in which that would happen at other institutions. And then lastly, it's just really important to make sure that you continue to talk about your patients about fertility preservation. It's a really, really critical component to reproductive health care for these patients. And it's really important that they get connected with us early and often so that we can talk about it. And shoot. So thank you. None of my photos showed up. Thank you to no one. Thank you to Dr. Macklin, who does just a phenomenal job taking care of trans patients and recruiting trans patients. And that's why I came to this program and why I'm able to do this research. Thank you to Dr. Chakmak, who was able to really come in and make sure that our statistical analysis was appropriate and really helped me finish the project. Thank you to the department for listening to me do this presentation multiple times. And then this is my 7th year at UCSF. So thank you to everyone here. I've met so many people and you've all impacted me and all of your support and mentorship. And with that, I'll take questions.
Similar, one question if you have it, Dr. Levin. Dr. Stark, great, important work. One question, and maybe you specified with your limitations, but I would think the finances around fertility preservation might enter into somebody's feelings about it. Everybody had insurance coverage or?
Yeah, that's a great question. So the question was, how did finances play into this? And I think again, we're looking at a very skewed population. I think most people probably have the means to afford this. And it's, but we didn't specifically ask, one of our other limitations is we didn't ask why they regretted it. That wasn't we only used the DRS. We didn't kind of jump into the why of it. And I think that, and if I were to do it again, I would have more of a qualitative component to the study where we could kind of explore what was the reason behind it. There was one other study that that was done by Molly Quinn, who's at UCLA. She's a prior fellow at UCSF, and she actually saw that finances were a huge reason of the why not, and also influenced regret. So I think that's a really good point, and definitely one of the major limitations of our study. We didn't assess that at all. Okay.
Good morning, everyone. I'm delighted to introduce Dr. Christine Blauvelt, who's just been an absolute pleasure to work with. She's brought this really rare combination of excellence as a clinician, a basic researcher, data scientist, and also a mentor to our junior trainees, which I'm really thankful for. In a short amount of time, she's contributed to the project that she'll describe today, but also others in the areas of infectious disease, environmental health, and reproductive science. And it's really, I guess, not a surprise when you really dive into her background, which includes an undergraduate degree at Princeton, medical school training at University of Penn, followed by an OB/GYN residency and MFM fellowship here at UCSF. And we're just so lucky to continue to work with her and continue this journey together here as she joins the MFM faculty. So with that, I'll hand off to Christine. Thank you.
Thank you, Josh, for that kind introduction. And thank you for the opportunity to present our work today on transcriptional alterations in placental Hofbauer cells in response to placental malaria. I have no disclosures. Malaria is a mosquito-borne parasitic infection endemic to over 80 countries. And every year, approximately 12 million pregnant people are exposed with serious risks, including preterm birth, fetal growth restriction, miscarriage, and stillbirth. In high transmission areas, malaria is actually thought to account for up to 1/3 of preterm births and about 70% of cases of fetal growth restriction. Placental malaria results from the sequestration of Plasmodium-infected erythrocytes in the inner villus spaces of the placenta, triggering a maternal immune response. This inflammatory process is thought to disrupt the maternal-fetal interface through disruption of nutrient and oxygen exchange and contributing to adverse pregnancy outcomes. The images shown are histologic cross-sections of chorionic villi. In placental malaria, which is shown on the right, infected red blood cells accumulate in the inner villus spaces, resulting in inflammation leading to fibrin deposition and syncytial knot formation. Hemozoin, which is a byproduct of parasite metabolism, accumulates in the inner villus spaces and in the chorionic villi and appears red under polarized light. The Rogerson criteria classify placental malaria into 4 categories: uninfected, meaning there is no parasites and no hemozoan; acute active infection, which means there are parasites without hemozoan; active chronic infection, meaning that you see both parasites and hemozoan; and past placental malaria, where you see hemozoans but no evidence of parasites. This study is going to focus on past placental malaria, which is the most common form where infection has resolved, but residual hemozoan remains. Hemozoan is a pro-inflammatory byproduct of parasite metabolism and is thought to result in chronic inflammation in the placenta even after parasite clearance. In placental malaria, malarial antigens cross the syncytial trophoblast layer, either due to disruption in the that's in the syncytial trophoblast due to inflammation, or via shuttling of the antigens across the syncytial trophoblast via Fc receptors, often bound to immune complexes. Once the malarial antigens enter the villus stroma, they encounter Hofbauer cells, which I'll talk about next. So Hofbauer cells are resident fetal origin macrophages that are thought to play multiple important roles in the placenta. Hofbauer cells are thought to play roles in fetal placental vascular development, tissue remodeling, regulating immune responses at the maternal fetal interface, and providing innate defense against pathogens that breach the placental barrier. In placental malaria, Hofbauer cells are known to increase in number, but their functional role in placental malaria remains poorly understood. So therefore, the objective of our study was to define transcriptional alterations in Hofbauer cells in response to placental malaria. We conducted a nested case control study within a double-blinded randomized controlled phase 3 trial investigating intermittent preventative treatment for malaria during pregnancy. The parent trial enrolled 2,757 HIV uninfected pregnant people in Busia district, Uganda. Placental malaria status was determined according to histologic grading by Rogerson criteria, and approximately half of participants had evidence of past placental malaria. We selected 4 cases of past placental malaria and 7 healthy controls for these experiments. Formalin-fixed paraffin-embedded placental tissue samples were analyzed using the NanoString GeoMx digital spatial profiler. This platform enables spatially resolved gene expression analysis by profiling selected regions of interest within intact tissue samples. Placental sections were stained with a panel of immunofluorescent markers to visualize tissue architecture and to identify specific cell populations. CD68, shown in yellow, was used to identify macrophages. Pan-CK, shown in green, was used to identify trophoblasts, and CD31, shown in red, was used to identify endothelial cells. Hofbauer cells were identified as CD68 positive macrophages that were located within the chorionic villi, whereas CD68 positive macrophages that were in the intravillus space, which likely represent maternal origin macrophages, were excluded from the ROI selection. Based on these morphology markers, ROIs were segmented to isolate Hofbauer cell-enriched areas from surrounding trophoblasts and stroma, and this allowed us to perform targeted transcriptional profiling of Hofbauer cells. The clinical characteristics were overall similar between the groups. Of note, there were more participants in the control group that were nulliparous. No participants had hypertension or diabetes, and infant sex distribution was well balanced. Birth outcomes were also largely comparable between groups. There were no preterm births. One infant in the placental malaria group had SGA, and the average birth weight and percentile was slightly lower in the placental malaria group. This plot displays the differential gene expression results. Each point represents a single gene, with the x-axis showing differences in gene expression and the y-axis showing statistical significance. Genes to the right are upregulated in placental malaria, while those to the left are downregulated. We identified 463 genes with an unadjusted p-value less than 0.05 and a 1.5-fold change in gene expression. While we acknowledge the increased risk of false positives without multiple hypothesis testing correction, this approach allowed us to cast a wider net in a small data set and prioritize genes for further biological interpretation. This heat map shows the expression profiles of those same 463 genes, with each column representing an ROI and each row representing a gene. There were 3 to 4 ROIs collected from each placenta. The colors reflect relative expression, with blue indicating higher expression or upregulation, and red indicating lower expression or downregulation. As expected, our samples clustered primarily by exposure group. However, I think what is notable is that the malaria exposed samples, which are shown in orange at the top, exhibit relatively consistent transcriptional profiles across the population, meaning the same sets of genes are either upregulated or downregulated. In contrast, when you look at the control samples, which are shown in blue at the top, they're equally likely to be upregulated and downregulated, which you can see by a kind of equal distribution of red and blue across the population. This suggests that placental malaria may induce a coordinated transcriptional response in fetal macrophages that is not observed in unexposed controls. To better understand the biological significance of these transcriptional changes, we next examined individual genes that were most differentially expressed between the groups. And we found that several of these genes were actually involved in pathways related to immune activation, immunomodulation, and tissue remodeling. And I'll go through some of them individually. MX1, IFI27, and IFI6 are interferon-stimulated genes that regulate macrophage responses to immune activation. They promote antiviral defense, and they shape the inflammatory environment to innate immune responses. In our data set, all 3 of these genes were significantly upregulated in Hofbauer cells, suggesting a sustained immune activation signature even after parasite clearance. Interestingly, upregulation of these genes has been reported in preeclampsia, in recurrent pregnancy loss, and in autoimmune conditions such as lupus and antiphospholipid syndrome, which are conditions characterized by persistent type 1 interferon signaling. Our findings suggest that in utero malaria exposure may induce a similar chronic interferon-induced immune state in fetal macrophages. In parallel, we observed downregulation of genes involved in immune regulation and resolution of inflammation, including IL-27 and ALOX15B. IL-27 is primarily anti-inflammatory in macrophages, and it limits pro-inflammatory cytokines, and it steers T cell responses towards a regulatory phenotype. ALOX15B generates lipid mediators that facilitate non-inflammatory clearance of apoptotic cells, thereby preventing the release of self-antigens that might trigger autoimmunity or inflammation. So we saw downregulation of these genes in Hofbauer cells, which ultimately may lead to altered immune tolerance and a pro-inflammatory environment in the placenta. Finally, we identified downregulation of PDGFD and TP73, which are genes critical for vascular development and tissue remodeling. PDGFD supports angiogenesis and extracellular matrix remodeling, while TP73 regulates cell survival and has been linked to trophoblast function. Downregulation of these genes may impair Hofbauer cell support for placental remodeling, particularly in the context of inflammation. Notably, PDGFD expression has been implicated in preeclampsia and fetal growth restriction. Finally, we performed GSCA pathway enrichment analysis to better understand the biological processes altered in malaria-exposed Hofbauer cells. This method looks at whether groups of genes involved in the same biological processes are either upregulated or downregulated in malaria-exposed samples, and this helps us move beyond individual genes to understand broader changes in how cells are behaving. This dot plot shows the top gene sets that were enriched in our data set. Each dot represents a pathway, with the size of the dot representing the number of genes in the gene set and the color representing statistical significance. And we once again saw strong enrichment of interferon signaling pathways and antiviral responses and immunomodulation. Additionally, there was upregulation of pathways involved in ATP synthesis and mitochondrial function, suggesting increased metabolic demands in the setting of past placental malaria. To conclude, our findings suggest that Hofbauer cells retain sustained immune activation following malaria infection and pregnancy, potentially perfecting immune memory or chronic activation that could be driven by hemozoin. Functionally, this persistent immune activation may lead to loss of immune tolerance and impaired support for vascular and tissue remodeling, which could have important clinical implications, including for things like fetal growth restriction, which is very common in patients with a malaria exposure during pregnancy. And this underscores the potential for targeted therapies to mitigate the downstream effects of past placental malaria and to hopefully ultimately improve pregnancy outcomes. There are several key areas for future work. First, we aim to validate our findings in larger cohorts to ensure the transcriptional changes that we saw are consistent across a broader sample. Second, we plan to link gene expression to clinical phenotypes, starting with fetal growth restriction, to better understand how malaria-associated transcriptional changes in Hofbauer cells may underlie adverse pregnancy outcomes. And then finally, we hope to understand how fetal immune programming is shaped by in utero malaria exposure. This includes identifying biomarker genes that could be used in Hofbauer cells to predict neonatal immune responses, for instance, which babies may develop clinical malaria in the first months to year of life. With that, I'd like to thank my incredible mentors and collaborators who made this work possible. A special thanks to Dr. Stephanie Gaw, who supported my research since I was an intern in residency, and to Dr. Nita Ozarslan, who taught me so much about working in the lab and who helped design and conduct these experiments. Thank you to Josh Robinson for mentoring me in bioinformatics. And thank you to the study participants, the IDRC team in Uganda, and the Preterm Birth Initiative for funding and sponsoring my research time during fellowship. And then, of course, thank you to my incredible co-fellows and to my family for their endless support. And with that, I'll take any questions. I know I'm standing between everybody and breaks, so.
Okay. I know this already, I know your N is 4, but do you have information about sort of the time frame between their prior malarial infection and when sort of, or just wondering?
Yeah. Yeah.
Immunologic sort of imprinting, you know, I'm sure you'll show this in your larger cohort. Does that sort of wane over time, or does that get stronger over time? Like the time since your past?
It's a great question. So as part of this cohort, they assessed malaria, they assessed parasitemia burden on enrollment, and then every month throughout the trial period. Unfortunately, because of the time frame in which people actually enter prenatal care, we don't exactly know about first trimester infections, which is probably the highest risk time in terms of impact of a malaria exposure on placental development. So this just shows the earliest gestational age at which the 4 participants had evidence of parasitemia. The average and SD were 16.8 weeks, but that was also probably the time of enrollment. And so that kind of critical window between when exactly in the first or second trimester did they first develop parasitemia is not known for this cohort. So it does make it, I think one of the interesting questions, especially for looking at fetal immune programming and risk of neonatal clinical malaria, is this question of when in the pregnancy did you first get exposed? But we don't have quite the granular data on when in the first trimester that they would have first been exposed, but presumably early on in these malaria endemic regions. Yeah. And that's also when people start intermittent preventative treatment for malaria. So you're not typically on preventative treatment, but it's standard of care in pregnancy to be on antimalarial treatment, but they usually start treatment when people are already into the second trimester. And so most of those people, given that pregnancy is a risk factor for developing malaria infection, even in endemic regions, not being on intermittent preventative therapy likely increases the chances of having parasitemia in the first trimester.
Take a short break and come back at 10:30.
Okay, I know that was the shortest break of all time, but we can like quietly come back to our seats so we can get going in the next phase. We have a guest. If we can quiet down the room, you can grab your stuff and come back to the seats. We have a fantastic guest appearance from one of our residents who wasn't able to present during resident research day. So here we go.
Hi, everyone. For those who I don't know, my name is Martha Tesfalol, and I have the pleasure of introducing our fabulous chief resident, Mariela Nevarez, who has been doing some incredible work here at UCSF. She actually has been part of the UC system for a long time. She actually did her bachelor's at UC Berkeley in clinical anatomy, I think, or biology with a minor in global poverty and practice. She then went to UCLA and was part of the PRIME program, which, if you haven't heard about it, is focused on community advocacy and leadership, and also did her MPP while there in Southern California. there, she did incredible work with medical school education, really focused on developing curriculum on anti-racism and reproductive justice best practices, which she has continued to bring to her work as a resident here. She also was engaged in work advocating for removal of police in healthcare settings when she was in Southern California. Here at UCSF, she has continued to be amazing in the social justice space. She was recognized with the Crevens Award as an intern, with residency teaching awards since then, and has also been the coordinator of the UCSF OB-PED Social Health Collaborative, through which there has been a lot of work revising CPSP reporting guidelines, optimizing care for patients with substance use disorder. And it has been part of the work of that group and Mariela to really think about how we can, in a systematic way, look at childcare needs in our birth center.
All right, thank you, Dr. Tessful, for that introduction. My project focuses on childcare needs on labor and delivery. And I wanted to start off by highlighting what inspired this work, which is our patients, obviously. We had a 30-year-old G4P3 with chronic hypertension who had an NSVD, who presented to OB triage postpartum day 10 with severe range blood pressures. She received 24 hours of magnesium, and we titrated her nifedipine. Unfortunately, we had suboptimal blood pressure control on postpartum day 12, but she decided to have a self-directed discharge due to hospital childcare policy and discussion of CPS involvement. So our patient, a mother of 3, encountered significant psychosocial barriers during her hospitalization. Hospital policy prohibited her from supervising her 3 children on site, and the only alternative offered by hospital staff to address the childcare issue was contacting CPS, which the patient felt was unacceptable. Although our patient understood and appreciated the importance of blood pressure control, the lack of viable childcare support, coupled with the threat of CPS involvement, caused her significant moral distress. And ultimately, after careful consideration and shared decision-making, the patient decided to have a self-directed discharge on hospital day 3 with close follow-up via telephone and triage visits. I wanted to ground us with this patient example to illustrate what we already know, that childcare is a reproductive justice issue, and how our medical system and hospitals can inadvertently serve as an extension of a state of surveillance with our policies and the threat of CPS involvement. And I thank you, Dr. Seidman, for highlighting some of the issues that often come up with CPS, like historically and contemporarily. So I recognize that we're all familiar with reproductive justice principles. I want to underscore that my project focuses on how folks should have a right to raise children in a safe environment and a supportive environment, as it acknowledges how an individual's intersectionalities affect your access and power. And this is where the issue of childcare comes in. And then this is a quote by Loretta Ross from Sister Song, one of the co-founders and one of the people who coined reproductive justice. I also wanted to contextualize this work by talking about Kimberly Crenshaw's landmark article on intersectionalities, where she radically changed the way that we understand violence against women. In her paper, she describes a Spanish-speaking Latina in crisis, fleeing from her home with her teenage son to escape threats of harm from her husband. She presented to a domestic violence shelter, who then turned her away because of their rule around English proficiency. So despite this woman's desperate need, she was unable to receive the protection that are afforded to English-speaking women due to the shelter's rigid commitment to exclusionary policies. So the shelter ended up failing to fulfill one of the core objectives of the shelter movement, which is ensuring the woman's safety by removing her from danger. And I feel like this really speaks to how they never imagined a non-English speaking woman who would be in need of these services. And I worry similarly that our failure to interrogate how having access to childcare as a reproductive justice issue will also be replicating and reinforcing these systems of oppression. These are some of the relevant UCSF birth center policies. I think we're all familiar with the visitor policy. And then here is also one of the mandated reporting policies that we have here at UCSF, where children 0 to 8 can't be unattended without supervision. And while there's very little literature around this, there are a couple examples of hospital systems that are actively working on this issue and thinking critically about how to support patients in this way with childcare. I think oftentimes when experts study barriers to care, there's more of a focus on transportation, nutrition, housing, insurance, but few had considered asking patients around childcare. So Dr. Kimberly Coe, who's an author in both of these papers, she interviewed 300 women at Parkland who had young children and found that when women were asked this question, the number one reason of why patients were missing appointments was childcare access. And then just of note, Parkland's a safety net health system in Dallas, Texas. Another gap that I think we saw a lot in the literature is there wasn't a focus on obstetrics. A lot of the focus was outpatient settings, and there was some literature around like folks receiving cancer care, but mostly coming out of Canada. Yeah, so to add to this work, but more importantly, to support our patients in need of childcare, we wanted to determine how lack of access to childcare impacts patient experience and care utilization in pregnancy, childbirth, and postpartum. And we also wanted to pilot childcare-related assistance and evaluate the impact on patient experience and care utilization. And we were hoping to do that through different phases. One is through an online survey to assess patient needs around childcare and related social determinants of health. And then we have a couple of target populations. One is patients here at the birth center identified to have childcare need, whether by attendings, residents, nurses, anyone that's facing patients. And then also through the patients in the comprehensive perinatal services program with children who would also be identified to have a childcare need. And then just to give a little bit more context to the CPSP, it's a Medi-Cal program here in California that provides enhanced prenatal and postpartum care services. And here at UCSF, it's operationalized in collaboration with UCSF Health's Office of Population Health, and folks are assigned to a healthcare navigator and go through these standardized assessments that are done at intake, second trimester, third trimester, and postpartum. And we feel like this could really allow for earlier identification of vulnerable patients. And this is because of some of the questions that are asked in the assessment around childcare. There's some questions that ask about whether folks have thought about childcare plans for labor and delivery, if they need help finding childcare, and if they've made arrangements for childcare. So collaborating with CPSP would be a great opportunity to easily identify and capture a community who would benefit from childcare services here at UCSF. And then this is 2 questions from our survey instrument. And again, going back to those critical frameworks, we want to question how we think about healthcare, how we think about childcare and the services that we're providing to families. And so we want to use a liberatory lens and not just rely on the construct of what our current hospital system offers. And so because of that, this second bottom question really asks folks like how they would prefer to receive some childcare, whether on site, like during clinic hours, at home. And this project is still ongoing. So I just wanted to acknowledge and give some recognition to some of the work that has happened and is continuing to happen. So in 2020, Dr. Tesfel, before I was here, this was in the time of COVID, applied to the UCSF Patient Care Fund and also to an external childcare company. There was some momentum, but again, because of COVID and all of those restrictions, unfortunately, we had a pause. And then in 2022, I also applied to the Patient Care Fund, not knowing that Dr. Tesfel had previously applied. So then they connected us both and shared some feedback. And there was like an openness to explore funding a pilot for this, as long as we like work through some of the logistical issues. And so from 2023 to 2024, we identified some unit champions, garnered some support from stakeholders. So we met with social workers, folks from general compliance, and also risk management. But it was in a lot of these conversations that we realized that just having a pilot might be a little hard. And so we then switched our focus to also do a survey design, go through the IRB, while still working actively on having some sort of pilot. So in 2024 to 2025, we worked on the survey design, explored different options for participant recruitment, like the CPSP, and then the IRB applications in progress. And then in the future, for future directions, we hope to implement the study and pilot for childcare, and could also involve some of you if you're interested. And so some of our key takeaways are, we know that there's unmet childcare needs that impact patient experience, care utilization, and in turn health outcomes. We know this from some of the limited literature that's out there. I think we all see a lot of this anecdotally, and hear this from patients. We also know that there's a disproportionate burden of our current policy on BIPOC and low-income communities, families, and then addressing childcare needs will also help us to advance reproductive justice within our care. Muchas gracias. I wanted to give some special thanks to Dr. Tesfalo, who's been doing this work for a long time, and has been very supportive in this project, Dr. Rosenstein and Dr. Sabani for encouraging me to do this project. There are a lot of barriers, as you can imagine, and so I was deciding between switching, but they were really encouraging around sticking with this, and I'm really glad I did. Dr. Corbetta Rostelli, who's also involved in a lot of these conversations, Didi and our nurses for being champions and supportive of this work, my co-residents who I feel like continue to advocate for our patients whenever this issue comes up on labor and delivery, and most of all to our patients who unfortunately take on the burden of highlighting how absurd our policies and our practices can be, and reminding us that we can envision alternative realities. And then of course to my mom, this is her on Mother's Day. Free to take questions.
Mariela, first of all, thank you. And Martha, thank you for highlighting this issue. It is such a huge issue, and your framing is so important, and it impacts our patients. For you is when you're designing the survey guide, have you piloted it with any patients yet? And if not, I just probably suggest you do so to just get them to talk out to you. What do you understand this question as, and how you can frame it in a way that makes it more?
Thank you. The question was around whether we've piloted our survey instrument with patients. We haven't yet. We did look at a few different other sources around making like survey, like the flow of the survey and like the readability and all of those issues that are important. But I think that's a good idea to pilot it with someone.
That's just awesome job. Thank you.
Thank you.
Good morning, everyone. I'm Olga Ram, and it is truly my pleasure to introduce our graduating urogynecology fellow, Dr. Jaber Saad. Jaber hails from Michigan. He received his undergraduate degree at the University of Michigan and completed medical school and residency at William Beaumont. And he's possibly the best and most enthusiastic ambassador Michigan has ever had. If you've had the good fortune to work with Dr. Saad, then you already know he is the kind of physician we all want on our respective teams. Clinically, he's been outstanding, an efficient, skilled surgeon who can problem solve and pivot when it's needed. His empathy and kindness are obvious, and he's deeply respected and trusted by his patients, office staff, residents, and attendings. He brings a calm ingenuity to every clinical encounter and curiosity and erudition to every conversation. Whether the topic is surgery, AI, history, geopolitics, or something else entirely, Dr. Saad can always be counted on to make the conversation richer. His presentation today reflects exactly that spirit. His research in the correlations between chronic genitourinary or pelvic pain and a history of chronic stress and/or trauma aims to highlight the multiple facets of the human experience that contribute to chronic pain. It serves to remind us, especially those of us who are surgeons, that pain isn't always something we can simply cut out. It's complex, layered, and shaped by many factors beyond the operating room. So with great pride and excitement, please join me in welcoming Dr. Jaber Saad.
Ram's flattering me, trying to make me cry. She already has an invite to the lake house in Michigan, so she doesn't have to try any harder. Okay. So thank you for the opportunity to present our work investigating the relationship between urogenital pain disorders and adverse childhood experiences. I don't have any financial disclosures. To start, I think we should talk about what trauma is. And when you speak of trauma in the medical context, we're referring to experiences that overwhelm a person's ability to cope. Things like violence, abuse, but also things like not having clean clothes to wear to school. Trauma can be acute, it can be chronic or complex, especially when it starts in childhood. And the key point here is that trauma doesn't just affect someone emotionally, it can change the way the body functions, rewrite how the brain processes stress. Think of trauma like a tree, with the roots being the abuse, neglect, the household dysfunction. They're often hidden but deeply embedded. They shape the trunk, the nervous, hormonal system, the immune changes that you see in the body. And the branches are the visible symptoms: chronic pain, fatigue, emotional dysregulation, and multi-system illness. When trauma is chronic or early in life, it can lead to central sensitization, a phenomenon where the nervous system becomes hyper-responsive, even in the absence of ongoing injury. In this state, the spinal cord and brain amplify pain signals, and inputs that are normally not painful, like light pressure or bladder filling, for example, can be misinterpreted as pain, a hallmark of central sensitization. And this is how routine sensations feel intrusive and unbearable to many of our patients. Trauma is not just a psychological experience, it triggers measurable biologic changes. And these biologic changes accumulate over time and contribute to long-term health outcomes, including GU pain disorders. ACEs, or adverse childhood experiences, are early life events that can disrupt development and health. The term became widely known after the landmark trial in 1998, the ACE study, which found that these experiences were not only common, but strongly predictive of poor health later in life. This study has shaped everything from public health policy to clinical screening, and is directly relevant to what we see in our patients in the urogynecology clinic. As clinicians, ACEs give us a framework to connect childhood experiences to adult health presentations, including pain. I won't get into the whole study, but essentially what they found was both stunning and straightforward. The more ACEs a person experienced, the worse their health outcomes were, not just mentally, but physically. And this wasn't just a trauma story, it's a public health story. I don't have it here, but future studies found that these patients die younger. I mean, it's really gone into all facets of healthcare. So our fellowship is combined between Kaiser and UCSF. And so this study, we did out of Kaiser, but at Kaiser Northern California, we implemented routine ACE screening, first in the pediatric population and then in the obstetric population, and most recently in all patients. And this slide shows our questionnaire. You see the abuse, household dysfunction, and neglect. And our questionnaire really reflects the original ACE questionnaire from the 1998 study, which was out of Southern California Kaiser. And then in the bottom is the total score, which ranges from 0 to 10. In urogynecology, several pilot studies have suggested an association between individual urogenital disorders and ACEs. Women with chronic pelvic or bladder pain report 2 to 6 times higher ACE exposure than women without these symptoms. And over half of patients with bladder pain syndromes report 4 or more ACEs, a threshold we know is strongly predictive of long-term health risks. The association may help explain why GU pain conditions are so refractory to pharmacologic and procedural treatments. Therefore, we designed a study to investigate the relationship between GU pain and ACEs in a large, diverse patient population. We wanted to examine how ACEs and GU pain prevalence differ based on clinical and demographic factors. Our study is a retrospective cohort, including all female patients age 18 and older from a large integrated healthcare organization who fully completed our ACE questionnaire within a 2-year period. And as I'm learning from the research process, research takes a long time. So now we've made it a 4-year period. It's not up here. It just took so long that we just expanded our IRB. So hopefully when we publish, you'll see the full 4-year data. The prevalence of high ACE score defined as 4 or more ACEs was compared among patients with and without GU pain. The patients with GU pain were identified using ICD-9 and 10 codes. Diagnoses were grouped based on shared pathophysiology, and our grouping was based on the NIH's chronic overlapping pain conditions made by the NIH's pain consortium group. And we also added conditions that were not included in there that also shared similar mechanisms. Our aim was to compare the prevalence of ACE amongst those with and without GU pain diagnosis. And these are our results. So this is the flow chart of our study population. We were able to identify a total of 7,111 subjects who met our inclusion criteria and were included in the study. Of these, 717, or about 10%, carried a GU pain diagnosis based on ICD-10 code. Compared to patients with no GU pain, patients with GU pain diagnosis had higher mean ACE scores and were more likely to have high ACEs, which was defined as 4 or greater. Importantly, we did not find a difference in the association between GU pain diagnosis with any individual ACE category. So having GU pain was not, for example, more closely associated with a history of sexual assault or unstable housing or a sense of being unloved or any specific ACE, but instead was associated with the absolute number of ACEs regardless of category. Patients with GU pain were significantly more likely to have a diagnosis of depression, anxiety, bipolar disorder, and substance use. And they were also more likely to have non-GU pain disorders, including fibromyalgia, IBS, migraine, and chronic fatigue. As you can see from our histogram, only about 1 in 5 adults in our cohort reported having lived through no ACEs. The orange line depicts the prevalence of GU pain on the y-axis relative to ACE score on the x-axis. And as you can see, the higher the ACE score, the more likely a patient is to have GU pain. The specific diagnoses which were most closely related with high ACE score were chronic pelvic pain, endometriosis, and dyspareunia. This matters for us in urogynecology because we're often the ones seeing these patients, sometimes after years of them bouncing between different providers. These disorders are highly prevalent but poorly managed, and the symptom burden is real and often compounded by trauma histories that go unrecognized. If we don't address that, if we don't ask, we often miss the full story. So in conclusion, our results demonstrate a dose-dependent association between adverse childhood experiences and GU pain. Our study underscores the importance of a comprehensive treatment approach to GU pain going beyond pharmacological and procedural therapies and addressing past traumas and their somatic manifestations. These patients are not non-responders, we're just not addressing the right problem. Clinical and research efforts should focus on the role of trauma integration in the management of chronic GU pain. And I just want to thank everybody who helped me with the research, especially Dr. Ram, who really gave me this idea during my first couple months of fellowship and got me really passionate about this, and everybody else in the fellowship and my family and my beautiful wife. So. Any questions? So It's already, so there, I didn't include it here. I have a longer version of this presentation where in other fields, so not so much in general urinary pain syndromes, but in other chronic pain syndromes, people are including, chronic or CBT and other psychologic treatments in the care of patients. So getting the standard treatment for pain, but also including the trauma and the treatment for the pain. And there's clinical trials happening in a few European countries as well to incorporate this. So I think we're going to be seeing more of this in the future, hopefully. And if I had another 3 years of fellowship, which I think one of the other presenters said if their husband or wife would kill them if they did, and my wife would definitely divorce me and leave me if I did. But if I did have 3 years of fellowship, I think that would be the next step is to design some sort of clinical trial that incorporates this. All right, thank you.
Hi, everyone. I'm Heather Huddleston. I'm one of the reproductive endocrinologists, and I'm going to be introducing Dr. Christ, who has been working with us in our division for the past 3 years. He comes from upstate New York. He went to Cornell undergrad and then Case Western for medical school, and then did his residency at University of Washington before we were lucky enough to have him come to work with us. Even before he came to us, he had done a bunch of PCOS research, both in undergrad with an investigator who's really well known in our field, Dr. Marla Lujan, and then he had also done a Fulbright fellowship where he did research in Europe. So he was already well experienced and well versed in so many research kind of ideas and concepts. So I was so lucky that he wanted to work with me, and he's done several really great projects. One that he really took the leadership of himself and got funding for that he's not talking about today, which is on CGM and PCOS. But he's also today going to talk about a project that we had been really interested in looking at sleep, because one of our interests in our PCOS research is the brain and how well it functions or doesn't function when patients have depression or other symptoms like that. So looking at sleep was something that was very interesting to us. He's done an amazing job with this project, as you'll hear. We are sad to see him go. He is going to be hopefully working with us very closely, though, as a partner and a neighbor at Kaiser, where he is going to be taking on, I think, an enormous amount of leadership, and will be probably running the place soon. But my goal is to make sure that we can continue to partner as research collaborators. So enjoy his talk.
Well, thank you for that introduction, Dr. Huddleston. It's been my honor to work with you these past 3 years. So I hope everyone is still awake for my talk, because I'm going to be talking about hormones, hypoxia, and hitting snooze, the sleep struggles of PCOS. And I can thank ChatGPT for the title for this talk. So I think many of us in this room are familiar with the reproductive symptoms of PCOS, with anovulation and resultant irregular menstrual cycles, increased androgens, and resultant clinical signs of increased hair growth, also known as hirsutism, and then classic ovarian morphology on pelvic ultrasonography. But in addition to these diagnostic criteria for PCOS, we also know that many women with PCOS have significant insulin resistance and resultant hyperinsulinemia. And likely this insulin resistance is tied to the pathophysiology of the disease, where androgens are thought to increase peripheral insulin resistance, and then resultant hyperinsulinemia results in increased androgen production. Now, just to kind of go back to basics, insulin has different effects on different tissues. So in a normal fed state, when you have high glucose, you get increased insulin secretion. And this insulin works at skeletal muscle to cause that glucose to get stored as glycogen. It also works at the liver to stimulate what's called de novo lipogenesis, where glucose is taken up by the liver and converted into triglycerides and either stored within the liver or sent to fat cells to be stored. And then also inhibits gluconeogenesis, so that way the liver stops producing new glucose. And finally, it inhibits lipolysis in adipose tissues to have decreased free fatty acid production. So overall, in a fed state, the glucose is being put into the skeletal muscle and into the liver. You're not going to produce new glucose, and you should decrease free fatty acid production. Now, in an insulin resistant state, there's basically kind of the opposite in all of these tissues. So there's decreased glycogen storage in skeletal muscle, and you have a lack of gluconeogenesis suppression in the liver. So you have inappropriate continued secretion of glucose from the liver. So you have all this increased glucose in the circulation. And then while the gluconeogenesis pathway is sensitive to insulin resistance, it seems that the de novo lipogenesis pathway continues to be stimulated by insulin. So because you have hyperinsulinemia, you continue to have de novo lipogenesis, plus you have all this substrate available. So you have all this de novo lipogenesis in the liver. And then in adipose tissue, you have lack of lipolysis suppression. So you have increased phe fatty acid production, which also goes to liver. And all of this goes to increased risk for fatty liver disease. Now, this tissue-specific insulin resistance is probably part of the reason why PCOS is associated with all these cardiometabolic comorbidities: visceral adiposity, dyslipidemia, NAFLD, type 2 diabetes, hypertension, and ultimately long-term cardiovascular disease. The comorbidity that I'm going to be talking about today, and which my project is focused on, is obstructive sleep apnea. And what's interesting is that obstructive sleep apnea really could be replaced with PCOS in this diagram because it's also associated with all these same comorbidities. And while we know that women with PCOS are about 7 times more likely to have obstructive sleep apnea independent of obesity, we really don't know why there's this relationship that exists. Likely, there are associations between the reproductive characteristics of PCOS with androgens and lack of luteal progesterone influencing sleep architecture and increasing risk for OSA. And then OSA, through intermittent hypoxia and increased sympathetic tone, may also exacerbate some of the underlying symptoms of PCOS. But common to both of these conditions is really this underlying insulin resistance and specific tissue abnormalities that likely drives both of these conditions. But we still really don't know the relationship between these two diseases. So that's what I set out to investigate further. We had 3 main questions that we wanted to look at. First, we want to see how baseline reproductive and metabolic features of PCOS relate to risk and severity of obstructive sleep apnea. We then want to see how treating obstructive sleep apnea in patients with PCOS impacted those features. And then we really want to dive into that tissue-specific insulin resistance to see how PCOS and OSA impacted those markers of insulin resistance, which I'll talk about. So to do so, we did a 2-stage prospective cohort study. In the first stage, we did baseline assessments and polysomnography testing on patients. And then in the second stage, patients with sleep apnea received CPAP treatment with pre and post CPAP assessments. In more detail, for the first stage, patients were included if they had PCOS by Rotterdam criteria, were age 18 to 45. They had to have baseline insulin resistance, and then they were at risk for sleep apnea based off of a screening questionnaire. Patients with diabetes, those getting treated for asthma, regular tobacco or alcohol use, those with HIV or hepatitis, and those with recent pregnancy or lactation, as well as prior obstructive sleep apnea treatment were excluded. All of the participants had an extensive baseline evaluation with anthropometric, hormonal, and metabolic profiling. And then participants underwent an overnight polysomnography test, which was scored by a trained sleep technician. Based off of that polysomnography test, our primary outcome was the apnea-hypopnea index, or AHI, which is used to diagnose obstructive sleep apnea and is basically an equation of the amount of time spent with apneas where you stop breathing or hypopneas where you have decreased breathing over the total amount of sleep time. And a score above 5 is considered positive for obstructive sleep apnea. For the second stage, then, those participants who had an AHI greater than 5 were eligible for enrollment. If they agreed to enrollment, they received 3 months of CPAP treatment. And then we did pre and post CPAP treatment evaluations for DNL, GNG, free fatty acid production, as well as markers of androgens, lipids, CRP. Now, I'm not going to go into too much detail about this, but just to say measuring de novo lipogenesis and gluconeogenesis is very challenging. These in vivo measures are relatively novel and techniques are kind of still being developed. So to be able to measure them, we had participants consume 5 days worth of deuterated water, so D2O, excuse me. During those 5 days, the deuterium gets incorporated into glucose as well as lipids. And then they came in for a 75-gram frequent sample oral glucose tolerance test, where they came in fasting and then had 10 blood draws over 3 hours. We then did mass spec on those blood draws to be able to evaluate the gluconeogenesis and de novo lipogenesis that was done during the OGTT. So we did that before and after each CPAP intervention. So because that is such an involved evaluation, studies that have published on that type of technique are relatively small, usually relatively small sample sizes. And you'll see that ours also is a small sample size. And it's really kind of preliminary data for future work and a proof of concept of can we do this type of study in this patient population and in this setting. So this is the enrollment results. So in total, we had 47 participants complete a polysomnography study. 1 participant had a non-scorable study. So we had 46 total scored PSGs. 19 of those 46 had an AHI greater than 5. And of those 19, 8 agreed to the CPAP intervention. Of those 8, 1 actually didn't complete the CPAP. So we have pre and post CPAP evaluations on 7 people. Then of those 7, I have data today on 3 of them. We're still doing the analyses on 4 of those participants. So I'll show the data on the 3 participants, and we're still in the process of completing that. So these are the baseline features of the participants who completed sleep studies. So you can see on average, they're aged 31 years. This was an overall obese cohort with the average BMI of about 36. These participants also had kind of the severe phenotype of PCOS, with 91% having hyperandrogenism and oligonovulation. And by design, the participants had evidence of insulin resistance with elevated fasting insulin, as well as 2-hour insulin, and an increase in the homeostatic model assessment of insulin resistance at baseline. These are the results of the polysomnography study. So as I mentioned briefly, 27 participants had normal AHI less than 5. 9 had mild obstructive sleep apnea with an AHI of 5 to 15, and then 10 had moderate to severe sleep apnea with an AHI greater than 15. So we first looked across the participants with complete polysomnography studies and looked to see how AHI associated with markers of cardiometabolic dysfunction as well as reproductive dysfunction. And as we expected, we did see that with higher AHI, we saw a decrease in HDL cholesterol, as well as increase in markers of insulin resistance with higher fasting insulin, as well as higher HOMA-IR. Interestingly, we didn't find any associations between AHI and any of the androgens that we looked at, but we did see a positive association between AHI and the LH-FSH ratio, and this was significant after adjusting for age and BMI. So it did seem like, as we expected, AHI associated with metabolic dysfunction, and it also seems like it may have some association with reproductive dysfunction, especially with gonadotropin secretion. This is the data for the participants that we have pre and post CPAP evaluations on, looking first at gluconeogenesis. So just as a reminder, as I mentioned in the beginning, in a fed state, normally gluconeogenesis should be suppressed after you have a glucose load. If you have increased insulin resistance, you're going to have a decrease in the suppression of gluconeogenesis. So if you have better insulin resistance, it's going to be suppressed more. So on these graphs, at time point 0 is when they came in fasting. And then if they have improved insulin resistance, the graph is going to go closer towards the origin because you're going to get a greater suppression of gluconeogenesis after that glucose. So that's basically what we saw. So pre-CPAP is in blue and post-CPAP is in red. And we did see an improvement overall in gluconeogenesis. The other way to look at this is the area over the curve. So you see an increase in that area over the curve. Subject 2, it looks like generally stayed the same, but it may be kind of some early signs that there may be some benefit. Similarly, for free fatty acid metabolism, after glucose load, you should have suppression of free fatty acid production. And so greater suppression suggests improved insulin resistance. We saw that especially for subject 1 and subject 2. And then overall, across all 3 subjects, there was a greater area over the curve, again, suggesting improved insulin resistance in the adipose tissue. And then finally, for de novo lipogenesis, again, in states where you have improved insulin resistance, you'd have less hyperinsulinemia and less substrate for DNL. So you would expect to have lower de novo lipogenesis with improved insulin resistance. And overall, we did see a slight reduction in de novo lipogenesis in the 3 participants that we have. So, okay, so what do we see overall? It appears that OSA severity does associate with markers of insulin resistance and metabolic dysfunction as we expected. And we also saw some association with gonadotropin dysfunction. So it seems like it may also be associating with some of the reproductive dysfunction in PCOS. We were able to use this novel deuterated tracer method to measure gluconeogenesis, free fatty acid production, and de novo lipogenesis. With a big caveat that obviously this is still very preliminary, this is only 3 people, it does seem like we're seeing some improvements in free fatty acid production, which would suggest improved adipose insulin resistance, and then improved DNL and gluconeogenesis would suggest improved hepatic insulin resistance. So next steps, we still are analyzing, obviously, the final samples for the pre and post CPAP participants. We've also extended our cohort study to include those participants who didn't elect to undergo CPAP treatment through our trial. So we're following up with them and getting additional labs to see if there's any changes in their features, not doing the full DNL and GNG assessment, but just looking at kind of more traditional markers of insulin resistance. And then we have an extensive battery of surveys on fatigue, cognition, depression, and we're going to look at how those associate with the information from polysomnography analyses and CPAP treatment. So with that, I'd like to thank the team. It's been a big effort to get all this work done. So thank you firstly to Dr. Huddleston, my primary mentor. Dr. Crystal is the primary mentor for the sleep studies. Dr. Schwartz is the primary person running the deuterated water studies. Our whole team at the Center for Reproductive Health, as well as a special thank you to Dr. Polly, Barracotti, and Castro, who were the ones who did the mass spec analyses for the DNL, GNG, and free fatty acid analyses. And with that, I'll take questions.
That was a great presentation. Thank you. I was curious, I appreciate that you're extending it to look at the patients who decline CPAP. I was curious what you know about those group of patients and how they're different from the patients who elected to do the CPAP intervention, so we can know how those who agreed to the CPAP are more generalized in that.
Yeah. It's a good question. I haven't really specifically like looked statistically to see what's different, but I can tell you from my kind of like personal experience. As you can tell, those are really involved studies of having to be able to come in and do those 3-hour blood draw visits, and it's very involved. So it's hard for people who don't live in San Francisco who are working full time. So it's often like those were the people that declined. And it's not necessarily that they had like less severe obstructive sleep apnea. Even some of our patients that had pretty high AHIs declined to do the treatment. And they then could just be seen in the sleep center and get treated through that. So they would get a free CPAP. They would get, you know, there were benefits to being in our intervention trial, but a lot of participants just didn't have the time to do so. So that was probably the biggest thing. Otherwise, you know, I think probably pretty similar in terms of baseline characteristics.
Presentation and okay, so in the vein of continuing fellowship for another 10 years, if you were to do the next intervention and trial, this brings up curious issues in my mind. You can't really randomize somebody to a CPAP machine because you know it's beneficial just in general. You know that's beneficial, and then so can you do something like we do? I know in contraceptive research you increase access to something. So you could have like, I don't know, you could have sites that have like a cluster trial with access to sleep apnea machines versus not, because how do you get gold standard data with something that you know is beneficial?
So
you really want that randomized.
Yeah, I'm laughing because I didn't talk about this because it takes, I don't have enough time, but this was originally a randomized control trial. And so we actually justified our randomization to CPAP versus a waitlist control because the waitlist to get into the sleep center was so long. And so it was like a waitlist control. Even if you got CPAP through our trial, it would have been faster than if you tried to do it through the sleep center. The problem is no one was willing to do that basically because they would come in, they would get their sleep study with us, they'd find out they had sleep apnea, and then they say, well, I don't actually want to do the randomized portion. And once you have the sleep study done, then your PCP can prescribe a CPAP machine. So then we had to change it to be a prospective cohort. And that's actually why the one of the 8 people didn't do the CPAP intervention, because they were in that RCT before we switched it over pretty early on. But we expected to have higher enrollment, and it just was hard to get people to agree to do the studies because they were so involved. So in an ideal world, I don't know necessarily. I think you're right. I think it would be hard to do that. Yeah, unless you have some kind of gap in access to care or something like that. You know, if you had a larger sample size, it would be easier to be able to evaluate with a prospective cohort, but obviously it's not as good. Yeah.
Thank you.
Hey, I have the great pleasure of introducing Dr. Ophelia Yin. So excited to hear about her work today. She came to us from her undergrad in Princeton, her medical degree at Hopkins, and then residency at UCLA, where she met my good friend, Dr. Yalda Ashfar, who sparked Ophelia's love of the transplant world. And since then, Ophelia has been doing some amazing work with the March of Dimes, with the transplant TPRI, Transplant Pregnancy Registry International. She's going to share some of that work today through that group. She's been super prolific in terms of her presentations, her a number of publications that she's had. I'm super proud of her. And I'm so excited that she's going to stay with us selfishly because we're going to get a center here started for transplant and pregnancy. And I know it's going to be an amazing thing to have her help spearhead it. And also super excited for her because she gets to end her long distance relationship with her husband because he will also be coming to UCSF. So we got two great people coming. And I'm so excited to have her present to you today.
Thank you so much, Dr. Rani, for that kind introduction. I'm really excited to present this work today. It's one of our projects through the Transplant Registry. So I'm going to talk about unintended pregnancy after kidney transplantation, risk factors, and associated obstetric and allograft outcomes. I don't have any disclosures. So transplant numbers are continuing to increase in the United States. This is some data from UNOS. So nationally, there's about 50,000 transplants that occur per year. This includes a number of different transplants. Of these, about 15% are in females of reproductive age. The most common are kidney transplants, but there are a large number of liver transplants as well as heart and lung. And then some other solid organ transplants that also do exist that we'll see more rarely are pancreas transplants, intestine transplants, and then vascularized allograft is actually where the newer kind of uterine transplant falls into for solid organ transplant. And how I became very interested in this is in residency, I had the privilege to take care of multiple patients with kidney or liver transplant in pregnancy, and these pregnancies are very complicated. So the good thing is that patients do better after their transplant than before in terms of getting pregnant. There's about a 70% rate of live birth, as you can see here on the left, but there's really high rates of preeclampsia, up to 30%, really high rates of preterm birth and cesarean delivery, up to 50%. And while rejection and graft loss is rare in the peripartum period, when it does happen, it's really devastating for both the pregnant person and the neonate. And so I have been able to collaborate with this amazing registry, the Transplant Pregnancy Registry International. They have been around since 1991, and they really study post-transplant parenthood and effects of medications on fertility and pregnancy. And so for this particular study question, we were really interested in unintended pregnancy. And so that's defined as a pregnancy that's unwanted or mistimed. About 45% of pregnancies are unintended in the United States. And there are many adverse outcomes associated with this, including depression and anxiety, relationship conflict, financial burden, as well as preterm birth and low birth weight. And really our main question was, in this really high risk population, and we really focused on our kidney transplant recipients, what are the risks and the effects of an unintended pregnancy? And this is especially important for kidney transplant because there's many considerations that we really hope to optimize before these recipients get pregnant, including ensuring stable renal function, reduction in infection, so making sure there's no active infection like CMV, and prevention, as well as immunosuppression stability. So all of these patients are on some kind of immunosuppression, usually prednisone, tacrolimus, and sometimes azathioprine. The other consideration for these patients is more recently mycophenolate has been used as a purine inhibitor for many of these patients. This is the most commonly prescribed version of this in the United States, called Celcept. But it comes with not only a 50% rate of miscarriage, but for neonates who are born exposed to mycophenolate, there's a really high rate of ear abnormalities such as microtia, eye abnormalities, and clefting, so oral facial clefting. So our study objective was really to understand the risk factors for an unintended pregnancy, the obstetric morbidity, and any allograft consequences for an unintended pregnancy in this kidney transplant cohort. So this was a retrospective cohort registry study. We compared these two, and our primary outcome was acute kidney rejection. So one of the great things about this registry is these outcomes were defined by histology. And so all these patients had a biopsy that demonstrated acute kidney rejection. And we defined this as the period in pregnancy or within 6 weeks postpartum. Secondary outcomes we looked at was graft loss, both within 2 years of the pregnancy as well as long-term graft loss. And then we looked at a composite of severe maternal morbidity. This is defined by the CDC, but includes things like hysterectomy, pulmonary edema, heart failure in pregnancy, as well as a composite of neonatal composite morbidity. These are things like necrotizing enterocolitis, intraventricular hemorrhage, and sepsis. This was our participant enrollment. So there were 2,030 pregnancies after kidney transplant. These are patients who had births between 1979 and 2019. We did exclude 307 where the participant didn't indicate their intention. And so this was self-reported, whether this was in the registry, the question was whether the pregnancy was planned or unplanned. There were 1,723 pregnancies in this registry study, of which 1,081 were intended and 642 were unintended. So there was a 37% rate of unintended pregnancy in this cohort. Our clinical characteristics, the unintended pregnancy cohort were slightly younger at 29.3 years of age. They were slightly earlier in terms of the year of the pregnancy, and there was a high rate of nulliparity at 57.6% compared to 51.1%. And then there was a significant difference in self-reported race. So 11.5% reported Black race for unintended pregnancy versus 4% in our intended pregnancy cohort. And then finally, there was higher rates of chronic hypertension in those who reported an unintended pregnancy. There were also differences in baseline graft characteristics. So these are just a few that we found were more common in an unintended pregnancy. They more commonly had a deceased donor graft instead of a living donor graft. More commonly, this was a repeat transplant for them, so their second or third transplant, and they had a shorter transplant to conception interval. This was one of the first outcomes we looked at was mycophenolate exposure. So in 1995, you can see here, this is when mycophenolate was FDA approved, and we were able to track this in the registry. So the dotted line is the unintended pregnancies, and the dark line is the intended pregnancies. And you can see them both go up as mycophenolate starts to be used. And then in 2006, it was reported as teratogenic. So you can see a precipitous decline in the intended pregnancy who are exposed to mycophenolate, but a continued exposure of up to 50% in some years for our unintended cohort. And this was significant when we took the average. So this was a 16% rate in the unintended pregnancy group versus a 5.7% rate of exposure in the intended pregnancy group. There were also increased rates of terminations in unintended pregnancies. So there's no difference in these other birth outcomes, but termination rate was 4.7% versus 0.4% in the intended group. And then interestingly, we didn't find a difference in obstetric morbidity. So those pregnancies that made it to a live birth, we took a look at preeclampsia, cesarean birth, all of these different outcomes. The rate of severe maternal morbidity was essentially the same, around 3%. The gestational age of birth was around 37 weeks. And then the neonatal composite morbidity was about 12%. So it could be that in this high-risk cohort, 3% is really high for those kind of adverse outcomes, that the intentionality didn't affect the high risk from an obstetric standpoint. But for our primary outcome, what we found was that on univariate analysis, there's a difference in acute rejection. It's 2.3% versus 0.9%. But when we adjusted for many of those different characteristics that predispose you to rejection, there's no difference in acute kidney rejection. But we did find a difference in the rate of allograft loss at 2 years from the time of pregnancy. So this means 2 years from the time of birth, this participant either had to undergo dialysis or a repeat transplant. So the difference here was 8.1% in our unintended group and 3.5% for an adjusted odds ratio of 2.27. We also took a look at long-term graft loss. So the left is a Kaplan-Meier curve that looks at survival. Unintended is in red. There is a divergence, but you can't do a kind of multivariable on a Kaplan-Meier. And so we did a Cox proportional regression on the right. And what we found is that when you adjust for other risk factors, long-term graft loss is not associated with pregnancy intentionality, but other things are more associated that we do know in other parts of the literature, things like donor type, creatinine, transplant number, year of conception, and mycophenolate. So in summary, in our registry study of 1,723 pregnancies after kidney transplant, the rate of unintended pregnancy was really high. It was 37%. Mycophenolate exposure was much higher in our unintended pregnancy cohort, and unintended pregnancy was independently associated with double the odds of graft loss at 2 years from delivery. And birthing outcomes did not differ by our pregnancy intentionality. And I think as I think about this going forward, these are all the different risk factors that were also associated with an unintended pregnancy, and these are some of our outcomes. But we know from our other literature that pregnancy itself doesn't increase your risk of graft rejection or loss. So we don't think that that's really what's happening. There are many unmeasured social determinants of health that are not in this registry that we really hope to look at going forward that probably connect this association between the unintended pregnancy and the graft loss itself. So that's something we hope to look at in the future. And then this is what we really hope clinically to do at UCSF. We really want to make kind of an obstetric transplant clinic or collaborative care model where we involve both MFMs from the pregnancy management side, but also complex family planning, our OB/GYN generalist division, some of our transplant nephrologists, our transplant surgeons, and of course the patient, their community, and our continued collaboration with our research registry. So I want to thank everyone who has supported me in many of these transplant studies. It has been such a privilege to be able to present our work around the world. Thank you to Dr. Rani for mentoring me in all of these projects, Dr. Asher from UCLA, and then Lisa Koskia has been an amazing transplant nurse coordinator who's been with the registry since 1991. So she's talked with thousands of these participants, and I've learned so much from her. And thank you to our fellowship and the division and department, my co-fellows, and my husband and our cats for supporting me. Thank you. I'm happy to take questions.
That was amazing. I have a semi-related question, but curious from the MFM perspective, and these are all patients on suppression. There's a lot of postulation about how the sort of early pregnancy and immune environment. Yeah. Are there any mechanistic or foundational knowledge from your cohort and your collaborators about
the question is if the immunosuppressant use in transplant recipients or the transplant in general affects the uterine environment in which the early placenta develops and then later pregnancy sequelae. So this is very much tied to another one of my interests on early onset preeclampsia. And I've thought a lot about this in the transplant population. And I really initially thought that the high levels of immunosuppression might improve some of those outcomes like preeclampsia, because we think there are some subset of preeclampsia that may be immunologically driven, but interestingly, it does not. One thing that we do know is that tacrolimus is very nephrotoxic and probably does drive much of the association with preeclampsia, but something we are hoping to do over time is really to understand more of both that placental environment and the immune environment going forward for these recipients. So we're kind of actively collecting blood, urine, and placenta so that we can study that further in the future.
Nice work. You demonstrated that there was a higher proportion of people electing not to continue the pregnancy in the sort of unintended group. And do you have data about are they sort of self-selecting out because they have more high risk factors compared to those who decide to continue an unintended pregnancy, or does that not sort of play out?
We did do a sub-analysis to look at just those where there was almost like a natural progression. So either they had a live birth, stillbirth, or a miscarriage to see if that data looked different than when you put in the people who had a termination or an ectopic, and we didn't actually see a difference. So we think that it could go both ways, but that the participants who elected to continue their pregnancy still had a similar risk as those who decided to terminate. Thank you.
Hi, everyone. My name is Jennifer Carlin. I am an associate professor here in the Department of Family Medicine at UCSF. I am a practicing family doc, and I also did my fellowship training in complex family planning here at UCSF, and I have a PhD in anthropology and history of medicine, and I have the great honor of introducing Emma Chu Murphy today. I have gotten the chance to work with Emma over the last 2 years on her fellowship project. She reached out to me at the beginning of her fellowship project because she was interested in approaching research from a community-centered perspective and working on the topic area of self-managed abortion. So I've been doing research in this area for about 7 years, and the topic has been getting sexier and sexier over time for unfortunate reasons. But it always makes me a little bit nervous when someone approaches me because jumping into this area is so high risk of criminalization for the people that we do research with. And so we have the risk of causing injury to some communities while we're engaging in this research because they're both targeted and vulnerable. But Emma approached me with such humility and grace and previous experience that made her really ready for this work. So she graduated cum laude from the University of Virginia, majoring in political and social thought, which has really helped her in this project. And then she worked as a community organizer for many, many years in New York City at various programs supporting immigrant LGBTQI, environmental health, sexual and reproductive health programs. She went on to achieve her MD from the Icahn School of Medicine at Mount Sinai, and then completed her internship and residency at Montefiore in the Bronx, where she became chief resident there before coming to fellowship here in complex family planning. So I can tell you that Emma has not let me down. The group of Emma advocates, patients, physicians, researchers warmed up to Emma immediately. She approached her work in a grounded way with curiosity and carefulness. She's helped build coalitions, led our community-based meetings with all of our community advisors and advocates, and has learned how to do qualitative analysis as if she had a PhD. Look, some people think that doing qualitative research is just, putting together some interview questions and then analyzing them. But Emma, on the other hand, she's worked tirelessly to iterate her interview questions, her coding tree, and to continually question her approach and her methodology and her own assumptions that she brings to this work. And that is actually what is needed to produce quality analysis in qualitative research. She's thoughtful, she's careful, and she's reasoned. And the findings from her work that she's going to present today will continue to contribute to the scientific record and will help many people who are trying to manage their reproductive health in their lives. So I am so delighted to also share that Emma will be staying on with us at UCSF after graduation. She'll be a generalist with a family planning focus in the AUGS division. And I'm so humbled to call Emma both a friend and a colleague, and I'm looking forward to writing many, many papers with her in the future. And these are some wildflowers.
Wow, Jen, thank you so much for that incredibly generous introduction. I'm delighted to be sharing my research with you, which is entitled Experiences with the Miscarriage and Abortion Hotline, Support and Validation Along the Spectrum of Self-Managed Abortion. So for some brief context, self-managed abortion, or SMA, is ending a pregnancy on one's own with little or no contact with the formal healthcare system. And this is not a new concept. And while the Supreme Court decision that overturned Roe v. Wade has certainly created many oppressive obstacles to accessing abortion care, self-managed abortion has existed long before this ruling and is recognized to be both medically safe and effective. In their most recent guidelines, the WHO recognizes self-managed medication abortion as part of a comprehensive range of options for pregnancy termination. There are a wide variety of reasons why people may opt for self-managed abortion, which may include privacy, personal safety preferences, personal preferences around having an abortion at home, as well as potential legal or structural barriers. And we know from prior research that rates of self-managed abortion are higher among trans and non-binary people, people of color, immigrant and uninsured communities. It's important to note before we get into this conversation that self-managed abortion really exists on a spectrum of informal and formal care pathways and can include either the entire process of the abortion or one or multiple of its component steps, which could include self-assessment for eligibility, self-sourcing of medication, administration of medications, or assessment of the abortion completion. So in response to the growing need for support for people who are self-managing, the MNA, or Miscarriage and Abortion Hotline, was formed in 2019. The hotline is a team of volunteer clinicians, including doctors, advanced care practitioners, and midwives who offer advice, medical advice, to those who are self-managing a miscarriage or abortion. This hotline is free and confidential, is open 7 days a week for 18 hours a day. And just important to note that this team of volunteers does not provide prescriptions, but does provide medical information. So since its inception, the hotline has supported thousands of individuals experiencing a miscarriage or abortion from across the US. And the number of individuals contacting the hotline has continued to increase, reaching about 50 to 60 contacts daily up to now. This graph demonstrates the significant increase in daily contacts comparing the year before Dobbs, shown in blue, with the year after Dobbs, shown in red. And the hotline receives calls and texts from across the US, with the greatest volume of contacts from the southeastern and southern states, including Texas. So the objectives of this research are, first, to describe the needs and experiences of individuals who contact the clinician support hotline in the process of self-managing an abortion. Second, to understand the role of this support hotline in people's SMA experience. And third, to explore how individuals navigate both formal and informal care systems during the SMA process. With this research, we really tried to aim to translate the MNA hotline's values into practice, and some of these Jen already referenced. So this includes a focus on autonomy, a focus on privacy, and really the avoidance of harm, given the potential legal as well as social vulnerability of folks participating in this study. We used a community-engaged approach, which meant taking into account the values of all of our stakeholders. This included researchers and volunteer clinicians from the MNA hotline, along with research collaborators from RISE, which is the Center for Reproductive Health Research in the Southeast, based at Emory University. And then we also received guidance and feedback throughout the process from We Testify storytellers, who are individuals who previously self-managed their abortion. So this study consisted of in-depth qualitative interviews with individuals who contacted the hotline during the SMA process. Our inclusion criteria were individuals currently living in the US who had contacted the hotline within the past 12 months related to a pregnancy and were able to complete interview either in English or Spanish. We excluded individuals who contacted the hotline on behalf of someone else or for questions not related to pregnancy, miscarriage, or abortion. This is a kind of summarized version of our recruitment model, but just to say that we spent a long time honing the details of recruitment to really think about both privacy and security for folks in the study. So participants, and we recruited from a larger survey study that was performed by the same research team. So participants, potential participants would contact the hotline first via text or phone call. And after their question had been answered, they would be given the option to participate in an anonymous online survey. After completion of the survey, which takes about 15 minutes, there was an option to provide a telephone number if they were interested in an in-depth interview. And we quite intentionally separated the data storage for the telephone number and the survey data so that there could be no way of connecting or identifying the survey responses. And then similarly, our methods were carefully reviewed for data and digital security. So participants first completed a brief telephone screening and verbal informed consent. And then semi-structured interviews were conducted over the phone and audio recorded using a USB recorder. We then transcribed using an offline AI platform called Whisper, and participants were offered a $40 e-gift card for their time. The transcripts were analyzed using both inductive and deductive codes. We had 3 people involved in developing the codebook iteratively, with 2 people independently coding and a 3rd team member adjudicating any differences. We then completed thematic analysis. So we had a total of 437 individuals respond to the online anonymous M&A hotline survey. And of these, 56 individuals were contacted for the interview phone screener after expressing interest in the interview. And recruitment was completed until thematic saturation was approximated, with a total of 28 interviews completed. Here is a table summarizing our participant characteristics. Participants had a mean age of 28, with a range of 16 to 42 years old. The majority of participants identified as people of color or multiracial, with about 25% as Black, 17% as Latinx, and 17% as multiracial, and about 11% identified as gender fluid or non-binary. This map demonstrates where participants were residing at the time of the interview. We can see the states in light purple had 1 participant, whereas the states in dark purple had 2 or more participants. And here you can see the concentration of participants was really in the southern and southeastern US. So for the purposes of this presentation, I'm going to be presenting on 3 themes, and I'll present a selection of data from the slides just to try to stay within my time limit here. The first thing I wanted to share is that the anonymous and individualized nature of information provided by the hotline was a key facilitator of trust. So just to note, the M&A hotline volunteers usually ask only minimal information or invite folks that contact the hotline to disclose whatever they feel is necessary to answer the medical question. And participants highlighted that this sense of anonymity really facilitated trust. As one participant from South Carolina described, the hotline volunteer was like, you don't have to disclose any of your personal information, just tell me what you're calling for and I'll help you to the best of my ability in everything. And I just felt safe. In spite of anonymity, participants felt that the information received from the hotline was individualized, and this was also a great facilitator of trust. As one participant from California noted, it was a personal answer. It was catered to me. In that moment, it was exactly what I needed. Our second theme is that the hotline provided essential clarity and reassurance amidst prevalent abortion disinformation. Multiple participants in both restrictive and non-restrictive environments cited the significant burden of navigating abortion information amidst many concerns about disinformation. This included the burden of checking and rechecking information to ensure legitimacy. As one participant from New Mexico described, I did 6 or 7 Google searches just making sure. I want to make sure that I'm finding the most accurate information and that all of this is lining up. Or another participant from Mississippi described, I really want this abortion, but I didn't want to basically put my life on the line. It was me digging and doing my research to make sure something was legitimate. In this milieu of mis and disinformation, the hotline helped people feel secure. The key role here was providing clarity and thus reassurance, oftentimes for answers that folks had already encountered. As the same participant from Mississippi described, the hotline gave me a little more relief. I had all these questions flooding my head, kind of ones that I knew the answer to. I just needed someone to reiterate the answer. The third theme is that amidst pervasive fears regarding the potential legal repercussions for self-managed abortion, the hotline provided a secure avenue to medical information. The majority of participants in the study expressed concern over the legal ramifications for self-managed abortion. This was more consistently true in restrictive policy environments, such as this participant from Idaho who expressed, I feel it's such a scary thing for anyone to do it in a state when you know it's illegal, you can get prosecuted. But this concern also extended to participants who were in states with more progressive policy environments. For example, a participant in New Mexico noted fear of even having a pregnancy on her medical record, stating, "I don't want any trace of it. I don't want my pregnancy to be within my medical file," just how turbulent women's healthcare is. Amidst the prevalent fear of legal repercussions, the hotline offered a direct and secure line to support. This top quote is from a participant in Arizona who, in spite of citing a strong and trusting relationship with her gynecologist, felt unsafe presenting to formal healthcare for abortion-related questions and was able to turn to the hotline. The second quote is from a young person in Florida who had legal concerns related both to self-managing and to her age. She found solace in the hotline, stating, "So the fact that I did have the hotline and I could talk to them made me feel a whole lot better about the whole process, because I had someone to share those thoughts with, and they could reassure me and tell me everything was going to be okay." We are continuing to analyze data and anticipate several more themes for the final manuscript. To offer a few concluding thoughts, I'd like to highlight that in this study, participants indicated that person-centered support and information can be established even in complete anonymity. And patients seeking abortion may be navigating a complex information landscape, including disinformation as well as information overload. Participants in the study valued the way clinicians served as trusted guides to help them towards reassurance and informed decision-making. And third, not surprisingly, our study, in contrast to prior studies, demonstrated participants were very worried about criminalization of self-managed abortion. The climate of abortion criminalization brings into sharp relief the critical role for clinician allies to support folks navigating between formal and informal care pathways while self-managing their abortion. This study has several strengths, including the direct connection and experience with people who self-manage their abortion, as well as recruitment in a variety of states and legal contexts, and the inclusion of young people, which is lacking in many prior studies. Some important limitations to note are that only English speakers ended up enrolling in our study, and that our interview enrollment required completion of a 15-minute online survey, which could pose both logistical as well as some literacy barriers, and that this study included individuals who had self-selected to speak to a clinician hotline, and so perhaps our findings may not be generalizable to a larger sort of cohort of people self-managing their abortion. A few next steps, I look forward to continuing the thematic analysis and then returning to our stakeholders, including folks at the hotline, our We Testify advisors, to think about how we want to disseminate this information in a way that's going to be both effective and in support of people who are self-managing their abortion. And also, in collaboration with our larger research team, hopefully develop a resource for people who work in abortion. I have so many people to thank. First and foremost, the participants for their wisdom, their bravery and courage, my incredibly sage and gracious PI, Dr. Carlin, my amazing fellowship directors, Dr. Kearns, Dr. Mangisha, and the wider CFP faculty fellowship community here, as well as many other people listed on this slide. Thank you so much. Banfield.
To the conditions of trust, given all of the disinformation, I'm curious if you asked about how folks felt that something, I'm guessing they saw on the, was a number that they were even willing to call.
Yeah, the question, just to try to reiterate, it was how people like contacting before they made the connection with the hotline, how they like decided to sort of trust it, more or less. And this was something I asked folks about directly, and hopefully will be part of the larger manuscript. Certainly the same like verification process that I described for information about abortion also applied to the resources. And people talked about how within the sort of network of support for self-managed abortion, which may include like the sources of the pills, potentially community sources, how the same resources showed up multiple times. And that certainly included the hotline maybe being recommended from multiple places, helped them to feel more comfortable. And then there were people that were quite honest and said, well, I wasn't sure I was going to be able to trust it, but I tried it. And then the trust developed. Great. Thank you so much. All right, I have the pleasure of introducing our last speaker for the morning. So Matt is our graduating MFM genetics fellow. Sorry, asthma's acting up, bear with me. So he studied biochemistry and music at Brandeis University and pursued research training for 2 years at Harvard in the Department of Stem Cell and Developmental Biology. He then went to medical school at the University of Vermont and completed his OBGYN residency at the BI. And then we were so lucky to recruit him here for MFM Genetics Fellowship, especially because he is from Sonoma County and was really excited to come back. I also will share, Matt and I went to the same high school, actually, interestingly, but I will not share the number of years apart we were. So during his time here, Matt has excelled in both MFM and genetics. He served as our administrative fellow for 2 years, as well as the chief genetics resident for a year. I don't know how you did all of that. He published many manuscripts and presented research at national and international conferences. And he recently received his first grant, which is the Earth Center Grant Seedling Award. So after graduation, Matt will be joining the Fetal Care and Surgery Center at Boston Children's Hospital. And we're so excited to see the wonderful academician that we know you will be.
Since we're short on time, I'm happy to forego questions at the end. And I remember in my interview when making the pitch to Teresa, I said we could make our high school have the highest number of MFM geneticists as alumni. Here we are. So I'm presenting my thesis project, a systematic review and meta-analysis of cell-free DNA testing for detection of fetal sex chromosome aneuploidy. I have no pertinent financial disclosures, but I'd love to update this slide. For background, since the discovery of circulating cell-free DNA in 1997, its use has rapidly expanded, and cell-free DNA is now recommended to be offered to all pregnant individuals in the United States. Cell-free DNA analysis enables non-invasive prenatal screening for the common trisomies, trisomy 13, 18, 21, the sex chromosome aneuploidies, and other conditions by detecting fragments of fetal cell-free DNA in maternal circulation. The test performance of cell-free DNA varies based on the genetic disorder being tested. The positive predictive value further for trisomy 21 increases with increasing ovum age. This is in contrast to lower positive predictive values that are seen for more rare conditions, such as 22q11 deletion syndrome. There's a freely available calculator online if you have a patient that receives either positive or negative cell-free DNA results, where you can put in the ovum or maternal age and the condition you're screening for, and it will give you a positive or negative predictive value. This is just an excerpt from an ACOG publication demonstrating how the positive predictive values vary based on the condition screened for, as well as with maternal or ovum age. You'll see for trisomy 21, the positive predictive value for a positive test is 38 to 80% when the patient's age 20, but this increases by age 40. The positive predictive value of a positive test is 91 to 99%. You'll see for trisomy 18 and 13, the positive predictive values are lower, but still increase with age. Sex chromosome aneuploidies are the most frequent aneuploidies in humans, with an estimated incidence of 1 in 440 live births. These are common disorders. The SCAs that are detectable with cell-free DNA include Klinefelter syndrome, which is 47XXY, Turner syndrome, Jacob syndrome, and XXX. Klinefelter among these is the most common, with a frequency of 0.16 to 0.24%. So though in genetics you think, oh, these are rare disorders, these are relatively common in the world of genetics. So we sought to determine the accuracy of cell-free DNA testing for detecting sex chromosome aneuploidies among singleton pregnancies using a systematic review and meta-analysis. We hypothesized that cell-free DNA would perform well for the detection of sex chromosome aneuploidies, but that variations in performance would be observed by the specific SCA disorder. We did this according to PRISMA guidelines using the PRISMA 2020 checklist. The protocol and aims were registered a priori on Prospero as they ought to have been, and this included only de-identified data from previously published manuscripts, making this exempt from IRB approval here at UCSF. We queried PubMed, Medline, Embase, Google Scholar, Chinal, and Lilacs, as well as clinicaltrials.gov for eligible studies. We excluded duplicate studies electronically by using the PubMed ID or the Digital Object Identifier, DOI. The initial cohort of titles was then cross-referenced against previously published meta-analyses evaluating cell-free DNA for SCA to ensure inclusion of potentially relevant studies. Our inclusion criteria included those reporting on singleton pregnancies that had undergone cell-free DNA testing between January 1st, 2010 and December 1st, 2021. They were eligible only if diagnostic genetic test results were also reported, which we determined to be at least 80% or higher in the cohort. Acceptable diagnostic tests included karyotype, FISH, microarray, or PCR. We also accepted genetic testing from either CVS, amniotic fluid, cord blood, POCs, or postnatally from any neonatal tissue to find the true positive and true negative test results. Studies underwent screening by title, abstract, and then full manuscript for inclusion and exclusion. And the full manuscript review was carried out by 2 researchers. Any disagreement on eligibility was then resolved and adjudicated by a 3rd researcher. And we performed a bias assessment as prescribed by PRISMA guidelines using the validated CODIS-2 tool. The meta-analysis of the 2x2 table summary statistics was then performed using exact binomial methods, or Klopper-Pearson, via the MetaPro package Instata. Force plots and pooled estimated sensitivity and specificity were calculated in aggregate along with their 95% confidence intervals. Separate analyses were carried out for individual SCA, but joint meta-analysis of sensitivity and specificity was not possible due to the high sensitivity and specificity levels seen for each disorder. We then calculated positive predictive values and negative predictive values using standard formulas. This is the PRISMA diagram showing our study selection. At first, we identified 31,718 studies through our database search, and there were no duplicates that we had to pull from other studies. Of those, luckily, we were able to exclude 10,877 duplicates, but this left 20,831 to screen by title. Of those, many were cell-free DNA tests outside of reproductive medicine for cancer and emerging things. If you're looking for investments, there's a lot happening in this field, 19,563 papers worth. We then looked at the abstracts for 1,200 of these papers and excluded 1,000 of them, leaving 241 for full article assessment. Of those, we excluded 220. Either they weren't reporting on the sex chromosome aneuploidies, they didn't have appropriate confirmatory diagnostic testing, or some other indication for exclusion. This left us 21 articles for the meta-analysis. These are our force plots showing the sensitivity and specificity for the studies included. The sensitivity for 45X is part A and the specificity is part B. The point is the point estimate and the line represents the confidence interval for that study for the range. And then you'll see the pooled summary statistic overall here with one higher sensitivity being to the right. The same results are shown in part C and D, and that's for 47XXY. You'll notice for sensitivity, many of the black dots are towards the right, meaning good sensitivity, but they have relatively large error bars. These are the force plots for 47XXX and for 47XYY. Again, the point estimates of sensitivity and specificity are quite high, approaching 1. So in summary, this is the cell-free DNA accuracy for the sex chromosome aneuploidies that we found. For 45X, the pooled estimated sensitivity was 98.754% and a specificity of 99.413%. The confidence interval is relatively narrow, 98.7 to 99.87% for the specificity. In general, these are quite high. Turning these into positive predictive values using the pretest probability by SCA is shown here, and I'll just orient you to the red box. So using an estimated prevalence for 45X or a pretest probability of 176 per 100,000, if we plug this into our estimates for sensitivity and specificity, we get positive predictive value of 22.9%. So this speaks to, although common. These are still somewhat rare, and the pretest probability for having a pregnancy with 45X is still low, even with exceedingly high sensitivity and specificities. The positive predictive value is 22.9%. This is higher for the other conditions that we looked at, 47XXY, positive predictive value 97.7%, 47XXX, slightly lower, 32 versus 61.6%, depending what you believe the pretest probability to be. So overall, we found high sensitivity, specificity, and high negative predictive values for cell-free DNA in the detection for sex chromosome aneuploidies. And estimates of the positive predictive value varied from 14.5% up to 100%. They were variable, the positive predictive values, across the SCAs, likely due to differing underlying disease prevalence. Notably, false negatives and false positives were reported. This study had several strengths. We included only studies with confirmatory diagnostic testing, which was rather rigorous. We included only studies in which the diagnostic testing was performed on 80% of those participants, and the final analysis included over 12,000 cell-free DNA test results, which significantly added to the published literature. There were several important limitations. We did not assess accuracy by the sequencing platform technology. There's some evidence that perhaps this may impact the accuracy of the test. And we did not include studies of multi-fetal gestations, although it's worth noting during the study period, cell-free DNA for SCA for multiples was not available in the commercial setting. Future directions. This is one of many meta-analyses published on this exact topic. So are we ready for a meta of the meta to really get down to the point estimate? I'd like to acknowledge my co-authors on this project who helped: Kate Swanson, Ria Garg, one of the other medical genetics fellows who's graduated, Angie Jellin, John Boskerden, who's made an appearance today, I think more than any other researcher on the slides, Mary Norton, and Teresa Sparks. Thanks so much.
Can I ask one question before people can go? So in some systematic analysis rubrics, assessment of bias, including commercial bias, is important. And in this study, you're not sort of, comparing hypotheses of whether something is or isn't true. But certainly many of these studies probably have a little commercial black box that you don't really know what inside of. Do you have any way of assessing that?
Yes, in the bias assessment, that was definitely part of it. Many of these studies that report these amazing results showing, one false negative were funded by industry. And so there's a high risk of bias of the underlying data for sure.
Congratulations again to all of our fellows and your amazing presentations. We'll give another round of applause. And I think from behalf of all of us, we can't thank you enough for how much you've contributed here in your years here, and can't wait to follow you along in your long careers. Congrats, everyone. Have a good rest of your Tuesday.